But to start off, we shall hand over to Dr. Mayer.
Hello, I hope everyone can hear me. Okay, so let me share the screen. Can you see the full screen, please?
Yes.
Okay, you can all see the full screen. Yeah? Okay, I'm Dr. Lin, one of the consultants from Queen Hospital. Today, I would like to start off with the topic, and which is quite common in both community as well as secondary care setting. This is how we should treat and how we should manage the osteoporosis treatment. Okay, so let me go to the next slide. Sorry, I was stuck just how to go to the next slides. Okay, so I think I passed the objectives. How can I go back to the objectives?
If you hit
backspace, that's it. Yeah. Okay, so I think the objectives for this topic today is that because when we see osteoporosis patient, we like to know which patient that we need to treat, and if we need to treat, we like to know which treatment we need to choose, and then after we initiate the treatment, we like to know when we can stop the treatment and what we should be doing after stopping the medications. So this is a very old osteoporostic classifications that established by WHO in 1994. So I think we all know the osteoporosis guidelines. In the definition is T-score less than minus 2.5. If patient has a fracture, we can call to establish osteoporosis with a confirmed fracture, which is a T-score minus less than 2.5 or equivalent to minus 2.5. So when you treat the patient, let me move this one. When we treat the patient, the challenge of the managing osteoporosis is because of the limitations of the drugs. We don't have a lot of drugs we have to choose, I have to say. So at the same time, some of the drugs are only applicable to postmenopausal women, and not a lot of drugs are approved, or not all of the drugs are approved for the gentleman. So I think you also have to decide whether are you using for the postmenopausal woman or are you treating the elderly gentleman. And because if I said not all the drugs are available or approved to use in gentlemen. And also age is also very important. Whether are you treating straightforward elderly patient with the bisphosphonates, or are you treating the younger patient or reproductive age, like for example, the young patient with the multiple vertebral fractures secondary to steroid use due to asthma, etc., etc. And also it is very important that we ask the patient what is the patient preference, whether they would like to take either oral tablets or whether they prefer to have an injections form. This is also very important with the patient's background medical history. For example, if patient has some sort of the absorption problem, like ulcerative colitis, Crohn's disease, they will be better fit with the injection form. Okay, if patient has some sort of the cirrhotic liver and esophageal varices, you don't want to risk their garlic. So that means that the injection form will be more suitable for the patient. And also we got some patients who got to osteoporosis secondary to anorexia, and that there is no way they can improve the bone density with oral treatments, and they will need the injection form. So it is very important that we ask the patient preference, and also we have to make the clinical judgment whether either you would like to give oral or injection form. And also risk factor modifications like body weight and vitamin D's, and the steroid use, and etc., etc. These are all the factors that we have to consider when you choose the right osteoporotic treatment for the patient. So these are the list of the medication that we have been using it for years. And the first one is basically pamidronate, etidronate that we have been using for ages. Now at present, we are using the last slide, the last bit, which is alendronate, risedronate, and abandronate, zoledronate, which is injection form. And we got a strontium again, which is injection form, teriparatide injection form, and denosumab injection form. So this is just a brief slide to see which drug work more on which are part of which type of the fractures. Generally speaking, the bisphosphonates, alendronate, risedronate, and the zoledronate, abandronate, they all work in the vertebral fractures. Apart from abandronate, it is not as so good in the hip fracture, so we should avoid the abandronate if you are treating the hip fractures. And risedronate, the strontium, it works in both vertebral and non-vertebral fractures. And raloxetine is mainly for the vertebral fractures. It's not very good in a hip fracture. That's one of the reasons this drug is not very popular. And teriparatide, again, it's a very good anabolic drug. It's very strong medication that to build the bone. However, it's not so good on the hip fracture. So we shouldn't be using teriparatide on the hip fracture patients. And denosumab is one of the drugs that currently we are using is also as a popular drug, and it works in both vertebral as well as non-vertebral fractures. So these are the risk factors, and I don't want to bore you by telling all the details, but we need to emphasize on the modifiable risk factors, such as correcting the vitamin Ds and changing the lifestyle, stop smoking, reduce alcohol. I'm not sure about caffeine, but I just added because it was recommended by National Osteoporosis Society, and low BMI and lean body weight and estrogen deficiencies and frequent falls. So these are the risk factors. We can certainly adjust this. We can amend this to minimize the risk of osteoporosis. And this is a FRAC score from Sheffield. And this is, I'm sure you all know that we have to fill the figures and glit, and we got the numbers, and that it's come up as whether it's a low threshold treat or non-treat. But if you look at our BHRUT osteoporosis result, you will see the three colors here. The one is the red color, which is you definitely need to treat it. So which is more or less straightforward. And if come up in the green color, then you don't need to treat this. You're confident with that. But sometimes there is a yellow color, which we call the gray area. So this is the area that we have to concentrate, whether we really need to treat the patient or we are not treating the patient. It also depends on the patient clinical risk assessment, as well as the clinician's clinical judgment. So bisphosphonates is just that inhibit the osteoclast formation. It is anti-resorptive drug that reduces bone turnover. So when you treat osteoporosis, actually we have to consider for duration of the treatment. There's two phases in the treatment of osteoporosis. The first phase is we call the initial treatment, which is actually 3 years. And the second phase is we call the extension of the treatment. So this is slightly different in this clinical area of the secondary care and the primary care setting. I know in our secondary care setting, we can get the DEXA scan very quickly. And ideally, from first DEXA scan and second DEXA scan, we should have about 18 months gap. This is mainly to see the changes in the bone. It normally takes for about 18 months to 2 years. So DEXA scan department won't be doing this if you request another DEXA scan before 18 months. However, there is a reason, if we have a good reason, and if we can tell the DEXA scan, look, this patient, we still not reached to the 18 months gap yet. However, we really need to treat the patient after 1 year, especially if you can't start the treatment and you want to wait and see what the bone density like for other reasons, that you can request after 1 year. I think this is in our secondary care setting. I think I understand in the primary care setting, that is a bit difficult to get the DEXA scan, especially if our GP colleagues are covering huge population. It's difficult for them and also time consuming. And I'm not sure whether it's going to be cost effective if you arrange a DEXA scan for every patient for every 18 months. I think this is one of the reasons when we see patients in our community care setting, there's a majority of the patients, or they are on the bisphosphonate if they come, but many of the patients they are using this for more than 5 years. So I think this is very important that we need to reassess the treatment after the initial treatment, which is the first phase, 3 years phase, see whether you should really need to continue 2 more years, which is we call the extension of the treatment. So the commonest drugs is alendronic acid, which is 70 milligram once a week. And this is, I understand, this is a first line drug because it is cost effective, and this is one of the cheapest drug. Risedronate is again once a week, but it is slightly expensive than alendronate, but risedronate has quite a lot of good things that I will emphasize later. And zoledronate is a 5 milligram yearly, which is a standard dose. If patient got renal problem, now we have to adjust the dose. We call it a renal dose, which is normally adjusted by our pharmacy. Normally it's EGFR less than 35, so the dose of the zoledronate become either 3.5 or 3.2 or 3 milligram. It depends on EGFR and a patient's body weight. And or we can also give abandronic acid, which is a once a week oral tablets. But if I say it's not very good in a hip fracture, so it is not actually not very popular medication. So these are the general side effects of bisphosphonates, but I'm not going to address all of them, but I would like to address some of the commonly asked questions that we came across in our rheumatology department. So here I'm going to address the oral bisphosphonate and oropharyngeal cancer, and I'm going to address the osteonecrosis of the jaw. I'm going to address bisphosphonates and dental work, and atypical fracture and bisphosphonate use, and finally I'd like to address osteoporosis, the bisphosphonate and pregnancy. So the oropharyngeal cancer, and actually we in the UK, so there's the biggest the study is mainly there's more than 2,900, so nearly 3,000 patients that they assess, which is in 2010. Which is oropharyngeal cancer is more common after 5 years of the treatment, and especially in elderly population. We don't have the study with a younger population, and if patients has aged for about 60 to 79 years of age, the woman has the incidence per year is 0.05 to 0.1%, because the figure says 0.5 to 1% per 1,000 patients. And if it is gentlemen, the incidence become 3 times. It become 1.3 to 3 per and 1,000 patients. There is one small study saying that this is not actually related, and with the cancer, there's no relationship between esophageal cancers and bisphosphonate, but the study is actually very small. So I think I'm going to ignore this. So if you look at the first study, so this is one of the reasons it is very important in elderly population. If you continue bisphosphonates beyond the 5 years without having any significant indication, that you just increase the risk of the osteoporosis to these patients. So,
Can you go mute, please? Who's making a noise?
okay, I think that's better. So I think if before we start the bisphosphonate, especially in elderly people, and we have to be carefully consider if patient is a high risk or the low risk. The high risk patient, that includes esophageal stricture and also breast cancer status, such as the Barrett esophagus with a high grade dysplasia, or if patient has an indigestion problem and you can't really find out what the reason is. So we better avoid this. And if it is a patient is a low risk patient, and after 5 years, so we make sure we stop the medication, and then after the repeat the DEXA scan, see whether is any indication to continue the treatment beyond 5 years. So this is with esophageal cancer. So osteonecrosis of the jaw, which is actually not a very, very common medical condition. It is actually for about 1 in a 10,000 or 1 in 100,000. So I have to say it is not actually very, very common medical condition. However, if this happens, and it is very difficult to treat, and it's a nightmare for the patient as well as the clinicians. So I think for me is I only see just once so far since I become the consultant in a PHRUT. So it is only one patient I have seen. So it is not a very common the condition. So again, the risk factor of the osteonecrosis is basically it's linked to the both oral as well as the intravenous bisphosphonates. And if patient is taking cancer and anti-cancer treatment, and also if patient has a poor dental hygiene, previous dental extraction, and a continuous dental procedures, poorly fitting, and if patient has a steroid use and a previous smoking history, and also the any pre-existing dental disease can increase the risk of the ONJ. So we need to ask properly whether, especially if patient is known to have a dental problem, we have to consider whether patient really need the treatment for with the bisphosphonates. I think this is what I meant we called as a gray area. So we have to make a mutual decision and between the patients and the clinicians how we should maximize the patient treatment. Again, the bisphosphonates and the dental work. I think in the UK, and we don't actually have the proper guideline for this. However, so I adapted the guidelines from the American Associations of the Oral and Maxillofacial Surgeons. What the surgeon said is the MaxFac surgeons said is if a patient has been treated with the bisphosphonate for less than 4 years, and if they have no other clinical risk factors, and they said we can do the dental work such as extractions and implants. That is if they have less than 4 years of the treatment, if there is no clinical risk factors. However, if patient has been treated with bisphosphonate for more than 4 years, or if they have other additional risk factors such as ongoing dental problem or bisphosphonate treatment, previous steroids treatment, poor dental hygiene, and etc., etc. I think if it is the case, they have advised that bisphosphonate should discontinue for two months prior to the treatment and a restart when the bone has actually healed. So I'm not sure whether the dentist in this country will agree with that, because I got quite a lot of osteoporotic patients, and they always ask whether they convey the message from the dentist. According to the dentist, they want to stop the osteoporosis 1 year before the dental procedure, which is not possible. And this is mainly, I think they're quite right to say this, because bisphosphonate is such a long-acting drug. They stay in the system for about a year. So what they said is quite right, but you have to look at from the patient sides whether how can they leave the patients or their osteoporotic treatment for the whole year, and just to increase the fracture risk. And also, if we continue the bisphosphonates, the patient cannot have her dental procedure for a year. So that means if they have whatever dental problem, whether toothache or crown fitting or implants or anything like that, they have to wait for the whole year. So I think this is very difficult, and it is almost impossible to stay without treatment for 1 year. It's not good for osteoporosis. It's not good for the dental condition. So I think if it is a case, so what I have done is I just speak to the dentist directly, and the dentist assess the high-risk procedure, low-risk procedure, and that we have to get the mutual agreement between the dentist and the rheumatologist, as well as the patients, see which will be the best benefit for the patient, and also make patients fully aware of the osteonecrosis of the jaw. So one of my patients that I only got one ONJ so far I have ever seen since I become a consultant, and she knows that there is a risk of the ONJ by starting the dental treatment, and she go for dental treatment and she got it. So there is nothing that we can prevent, unfortunately. So what I have to do is I have to stop the bisphosphonate treatment. So I can't restart any of the treatment. I just leave the osteoporosis without a treatment, just optimize the risk factors like her lifestyle, and she now stopped the smoking, and also make sure that we treat the vitamin D aggressively. So that's how you have to adjust the treatment in a patient who is in the gray area. Again, the atypical fractures and the bisphosphonates, the most common area is the femoral shaft. And there is sometimes that they recall the trauma history, sometimes they didn't recall the trauma history. They might probably say it's just a dull aching pain in the groin or in the thigh. So I think in the community that you can easily request X-ray. The problem is that there is not a lot we can see on the X-rays. Ideally, this patient needs an MRI, and if they got any metallic problem and if they got any implants and etc., they can have a CT of the bone. So this is just a plain X-rays that I just the uploaded. So if you can, the first slide that you can see that there is a elevations of the periosteal area, which is the site of the stress fractures. In the second picture that you can see, there is a linear crack due to atypical fractures secondary to bisphosphonates. So the last side effects that I like to address on bisphosphonate is the bisphosphonate and the future pregnancy. So bisphosphonate is not safe in pregnancy. We got a very little human data, so we can't rely on this. That sample size is very small. However, in the animal study, it was shown to have a teratogenic effect. So we have to presume that this is not safe in pregnancy. So it is not applicable if you treat the patient, elderly patient or postmenopausal age osteoporosis. However, if I did mention in the very beginning, it is quite applicable if you treat the young patient. So young patients suffer osteoporosis for many reasons, like if they got anorexia and they got osteoporosis, they have a malabsorption syndrome, and they have the gut resection secondary to UC or Crohn's disease, and also if they got I have seen a patient, a very young patient, only 23, who suffered a very severe osteoporosis with multiple vertebral fractures secondary to a massive steroid use that she has been using since teenager due to her brittle asthma. So this patient, if you got that sort of patient, especially the young patient, you have to be very careful because bisphosphonate is not safe. So in the bisphosphonate, in the ideal situation, that we only use a two drug, which is either alendronate or risedronate. The alendronate is it has a higher half-life, and the risedronate is a shorter half-life. So we can use a shorter half-life drug if patient has a pregnancy issue, or if patient has a renal problem, and if you want to treat the patient, and also if there is any problem, you want to get rid of bisphosphonate very quickly from the system, then you have to choose risedronate. So in the younger patient, so basically I use the risedronate, and what I tell is that they have to stop 1 year before they would like to start the family. So that should be a planned pregnancy. So stop the bisphosphonate 1 year, the risedronate 1 year, and then you can start from the pregnancy. So if patient is already on bisphosphonate, which is a relatively long acting, like for example, like alendronic acid, they might have to stop 2 years before starting the family. So there is no actually the full data to confirm that you have to stop 1 year, we have to stop 2 years, you have to stop 3. We didn't have this, but what we know from sure is a risedronate is a relatively shorter acting. So it is, we have to say it is relatively safer, but you still have to stop 1 year before starting the pregnancy. And it is also applicable in patients with a renal impairment. So, so you can use the risedronate if the eGFR is more than 35. But however, if the eGFR is less than 35, patient has a renal impairment, if you like to treat the osteoporosis, please refer patients to secondary care. In a secondary care setting, what we normally do is that you can do two ways. The one is that you can use denosumab, which is relatively renal friendly, but make sure you monitor the renal function properly, and also make sure you monitor the calcium level, because the risk of the hypocalcemia is high in patients with a renal disease. Alternatively, if you want to give for some of the patients, they don't meet the criteria for to give bisphosphonates. So bisphosphonates, if you want to give bisphosphonate as a secondary prophylactic treatment, which is fine. But if patient hasn't had any fractures, if you're using as a primary prevention, then you need to have a very high T-score. So if you don't have a high T-score, then you can't tick the box and you can't use the denosumabs. So alternative treatment, what you can use, or what we use, is that you can use the risedronate once every 2 weeks rather than once a week. That means you instead of using 4 times a month, you just use 2 times a month. So you have to tailor your treatment regime to match with the patient's renal function. So so if you start the bisphosphonate, and then there will be time that you have to consider changing the treatment. So there are a few factors that you have to consider changing the treatment. One of the commonest scenario is the patient non-compliance. I got so many patients, they said they just didn't take the medication. I don't know why. They just hate bisphosphonate. They're not taking this. So they admit that. They say, I'm not taking your medication. So they come to clinic just saying that, because I'm not surprised my bone density get worse because I'm not taking medication. When I ask why, oh, I forget, or I hate the taste, they have a reason for this. So if the patient is non-compliant and you have to change to intravenous, you have no alternative. Or patient have intolerance to medication, please change to intravenous medication. Or if patient sustained another fracture despite treatment, then please change to intravenous medication. Or in the repeating DEXA scan after 18 months to 2 years, if there is no improvement in the bone mineral density, then please consider for alternative treatment. So if they are on oral bisphosphonates in the community setting, if you need to escalate, you can either escalate to solandronate or denosumab or teriparatide. And if patient needs intravenous form, and please let us know or refer the patients to our department, so that if you find difficulty to getting the repeat DEXA scan, we can do it from the secondary care, and we can risk assess the patient again, and that we decide whether what type of the injection form will be suitable for the patient. Because solandronate is a once a year, so they came to our department and spend half of the morning day case. They have a solandronate every year, and then they go home. Denosumab is we do the first injection, and then after the subsequent doses is given by the GP. So I know now some of the GP surgeries, and they can even give the first dose by themselves. So teriparatide is a purely secondary care setting. So if patient needs a teriparatide, then you want to build the bone very quickly, then please refer this patient to our department.
Just to let you know, we've got 10 minutes to the next presentation, and we've got a few questions in the chat already. So
okay. So, so basically, this slides is a strontium. Okay, so the strontium is actually a drug, and I'm not sure whether you all aware the strontium is now back to the market. So it is a 2 gram once a night, but you have to be careful. But you have to assess properly whether they have any peripheral vascular disease, ischemic heart disease, or
क्या adjust करना है? Workplace project management is employee उसको.
Okay, so ischemic heart disease, thrombotic event, so we have to ask properly. Teriparatide, purely secondary care setting. Denosumab is so you can start from your primary care setting, or you can give the first dose and refer patients back to you or secondary care setting. So, so I think this is the for denosumab. So the only thing, one of the most common side effects I like my GP colleagues to be aware is basically hypocalcemia. The risk of the hypocalcemia is more common if patient has a renal impairment, especially creatinine clearance less than 30. So we make sure that we check the adjusted calcium level before starting the medication, make sure they got a normal vitamin D level. Please treat the vitamin D aggressively if you want to treat the patient with denosumab, and please repeat the blood test 2 weeks after the treatment. I think this all are on the share care guidelines, which is given by our department. The denosumab is actually, we have to say, it is not safe in pregnancy. So for denosumab is the previously we can use up to 2 years, and then after that we know that we can use up to 5 years. Now that we had a very good studies saying that now we can use denosumab up to 10 years. Yeah. So if you want to treat the denosumab, or if you're treating your patients with denosumab, please start with the 2 years, and then after that, before you continue beyond 2 to 3 years, please let us know for further risk assessment, and that we can continue for 5 years. And then after that, we can make decision whether we can continue beyond 5 years. So I have some of the denosumab patients, which they are now using for about 7 years, and so far they have no problem. So I think this is my last slides. Okay, so so it's a summary, and when you treat the patient, make sure you optimize the risk factors, and also please always consider changing the medication if they are not responding to treatment, if they are not compliant with medication. And also please do not stop the treatment without a plan. For example, if you treat the denosumab, 3 years you want to stop this, you must consider continue with one of the alternatives, or all the patients with the denosumab, they will need a DEXA scan as the interval phases, and then we should review the guidelines regularly. And also, if you're stuck and if you think you need a second opinion, please refer patients back to our department. Okay, thank you very much. If you got any questions, and please let me know.
Thank you very much for that. We do have some questions in the chat function. And I'm going to try and pronounce some of these names. So the duration of the bisphosphonate treatment, any local guidance?
The duration of the bisphosphonate treatments is basically initially we can start if I said before, the initial treatment is going to be 3 years, and then after the extension of the treatment is 2 more years, so totally 5 years. So ideally they should have a DEXA scan before treatment, after 3 years, and after 5 years.
Excellent. There's another one. I believe strontium has been taken off the market.
And now it's back on the market again. It is available in our BHIUT pharmacy, but if I've said you have to consider cardiovascular risk factor properly. It's 2 grams once a night. It's a very good drug.
Okay. Do we need to do a DEXA scan after 3 years of bisphosphonate treatment, and then when to repeat?
Ideally, in a clinical care setting, yes, we do repeat the DEXA scan every 3 years. But in the primary care setting, if you're stuck and if you think patient has no problem, you can continue 5 years.
Okay, thank you. And if we suspected ONJ, should we stop BP immediately? And for cases of suspected ONJ, who do we refer to? I have been told Guy's Hospital is our nearest specialist centre.
For my ONJ patient, if yes, we stop the bisphosphonate, and then after that, just refer to MaxFax. So the MaxFax is the main specialty to look after ONJ and to combine with the dentists.
Okay, and finally, is the duration of treatment still the same if using denosumab or IV zoledronate, i.e. 3 to 5 years? Is there a place for daily bisphosphonate? Is osteoporosis associated with pain, and how is it best managed? So there's a couple of questions in there, about 3 questions in there.
the way that we treat, if you start denosumab or IV solantonate, so it's a 5 years of duration and you would like to stop the treatment, the best way is to repeat the DEXA scan. If you want to continue this, either you can continue oral bisphosphonate, or you can continue denosumab. I'm not very fancy giving a solantonate beyond 5 years, and I think I personally want to stop this because of the high risk of the atypical fractures. And now, but after I stop the solantonate, I have to consider alternative if patient's still osteoporotic. So I think I might probably change to denosumab. This is one of the reasons, because if your patient's already on bisphosphonate for 5 years, so you can do you can't use another bisphosphonate. So I have to go for denosumab. This is one of the reasons I mentioned that the main trick, or the main the issue with the osteoporotic management is the limited use of the medication. We didn't have a lot of medication to use at present.
Okay, and we've one more just sneaked in. Does Truxima with osteoporosis treatment increase the risk of side effects?
This is not what we're aware of. We got a patient with the Truxima that we use for the either lupus or rheumatoid arthritis. They are on osteoporosis treatment. So far, I didn't recognize any big issue from it.
I'm on mute. Any final questions before we hand over to our next presenter? Oops. No, fantastic. Dr. Lin.
Can I ask you a question, please?
Oh, we have one question just.
Yeah. Can you give calcium with vitamin D along with the biphosphonates?
Sorry?
Can you give calcium with vitamin and the biphosphonate?
Yes, we can give calcium and vitamin D along with bisphosphonate, but I think this is one of the things that we'd like to address. If patient has a cardiovascular or the risk factors, or a patient has a strong heart history like ischemic heart disease, heart attack, the calcium is not very friendly to the heart. So I think I personally changed to vitamin D, pure vitamin D. So I stopped the calcium and vitamin D and check the vitamin D level and to give the pure vitamin D. And we'd like to aim the level more than 50.
Thank you.
One more question. How long will the patient be on the treatment in the second phase to reduce?
In the second phase of the treatment, I would say please stay in treatment for about stay on the second phase 2 years. That will make a total duration of the treatment for 5 years. And then after that, we can make decision whether they should continue beyond 5 years.
Thank you very much. Any final questions for Dr. Lin? No, that's fantastic. Dr. Lin, thank you very much for a very interesting presentation. I will now hand over to our second presenter, Dr. Daniels, Dr. Louise Daniels.
Hi, good afternoon, everyone. Thank you for inviting us to speak to you. Can you hear me okay?
Yes, we can.
Yes.
So I'm just going to share my screen with you. Okay, is that okay? You can see the screen?
Yes.
Okay, so I'm going to talk to you about the differentiation of osteoarthritis from rheumatoid arthritis, trying to provide some guidance to facilitate that differentiation in primary care, and also to look briefly at what factors might necessitate referral to secondary care. I'm going to look first of all at the pathophysiology and epidemiology of the two conditions, and then work through some slides comparing the clinical features. Got a couple of very brief case studies, and then I will touch very, very briefly on treatment, because that could be a talk in its own right. So rheumatoid arthritis is an inflammatory autoimmune condition. It typically affects the small joints in the hands and feet, and it's usually symmetrical. Any synovial joint in the body can be affected. And it's a systemic disease, it's autoimmune, and so it can affect any organ, not just the joints. You can get heart, lung, eye involvement, skin involvement, any organ. This diagram represents a joint with rheumatoid arthritis, and you can see the predominant feature being this very inflamed synovium. You get an increased collection of synovial fluid, the capsule becomes stretched, the synovium is inflamed, and then you get these erosions that occur at the corners of the bones. Osteoarthritis is a more localized process rather than a systemic disease. It involves all the structures in the joints, not just the synovium, so the cartilage and bone are affected as well. It's not just wear and tear, although we do often refer to it to our patients as wear and tear in the joints. The initial process is the breakdown of the cartilage, which covers the ends of the bone. And as a result of that, you get remodeling of the adjacent bone. The joint space becomes narrowed. You end up with these extra bony outgrowths, bone rubbing on bone, and then localized inflammation, which results in pain and swelling in the joint. And this diagram shows us in osteoarthritis. You can see here in the middle, you've got this thinned cartilage. The edges of the bone become rough and grow out with these little osteophytes. As a result, the synovium becomes inflamed, the capsule is stretched. So that's all the components of the joint being affected. And then just to see them all side by side, you've got your normal joint with its healthy cartilage, normal bone, nice synovial membrane with this joint space narrowing, loss of cartilage in the osteoarthritis, and this big inflamed synovium with extra synovial fluid and bony erosions in rheumatoid arthritis. So moving on to a comparison of the two conditions directly, in terms of epidemiology, osteoarthritis is obviously much more common than rheumatoid arthritis. It's the most common type of arthritis, around 8.5 million people affected in the UK. And in one study, X-rays in the over 65-year-olds revealed evidence of osteoarthritis in at least 50% of people, which compares to rheumatoid arthritis, which has a UK prevalence of around 400,000. The incidence is relatively low, so there's about 12,000 new cases a year, which equates to about 5 in a population of 10,000 people. So, in a GP practice covering 10 to 20,000 people, you might expect to see 5 to 10 new cases of rheumatoid arthritis per year. Osteoarthritis tends to come on in later life, so increasing age is a risk factor. Rheumatoid arthritis occurs most commonly between the ages of 40 to 60, but it can occur at absolutely any age, from the childhood onset, juvenile onset, right through, and people in their 90s can get new onset rheumatoid arthritis. So looking at the risk factors, female sex is a risk factor for both conditions. In rheumatoid arthritis, females are affected about 3 times more commonly than men. There's certainly a genetic component to the disease. Increasing weight, smoking, and dietary factors do contribute. In osteoarthritis, we've already talked about increasing age, but also obesity is a big contributing factor. Previous injuries to the joints, genetic factors again that come into play, and there may be an underlying previous inflammatory arthritis which has caused some joint damage, and people have developed secondary OA. Rheumatoid arthritis onset is usually fairly rapid, not always. There are cases that trundle on for years, or maybe palindromic in onset with flares that occur weekly, monthly, a couple of times a year for many years before it starts, but usually it's more rapid over weeks to months. Osteoarthritis, on the other hand, tends to be a bit slower, so people have gradually increasing pain over a number of years. The joints in rheumatoid arthritis are typically very painful, very swollen, and very stiff. Whereas in osteoarthritis, people might describe more aching in the joints, that they're tender, particularly in the hands. They can be tender if they get knocked or touched. There can be there can be swelling. So as I described earlier, you get this localized inflammation in the joint. So in the early onset, you can get these swellings that occur, but typically the swelling is less than rheumatoid arthritis, though you may have the bony swellings. So DIPs develop Heberden's nodes, and the PIPs, the middle joints in the fingers, get the Bouchard's nodes. People might describe a lot of clicking and creaking in their joints, which is crepitus, or they may talk about the joints giving way, the knees give way on stairs, they've got joint instability. So comparing the pattern of joint involvement, rheumatoid arthritis is usually symmetrical. It typically affects the small joints in the hands, but also any of the large joints in a symmetrical fashion. And within the hands, it's the MCPs, which is the joints across the knuckles, and the PIPs, the middle joints, that are predominantly affected. Osteoarthritis is usually asymmetrical. It tends to be the big weight-bearing joints like the hips and knees, or the joints that are used more frequently for everyday activities like the first CMC joints, the joints at the base of the thumb, or the DIPs that become affected. And this is quite a nice little diagram just showing the comparison. I think you can hopefully see my mouse hovering over. So I'm looking on the right-hand side at rheumatoid arthritis to start with. So you can see the MCPs and PIPs are affected, the wrists, the elbows, the shoulders. They can get cervical spine involvement, knees, ankles, the mid-feet, and then the MTPs. So it's very symmetrical, and it's very much those joints as described. Osteoarthritis, on the other hand, being the DIPs and the PIPs, the first CMC joints, the joint at the base of the thumb, you've got this asymmetric hip and knee, they may have cervical and lumbar spondylosis to go with it, and then they may have the sort of first MTP bunion type osteoarthritis in the feet. Just got a couple of diagrams looking at some examples. So on the left-hand side, you can see this, fairly obvious swelling in these PIP joints here. But on the right-hand side, I'm sure you can appreciate this sort of puffiness across the MCPs, but that's just to show that it can actually be quite subtle, the changes. Sometimes getting the patient to clench their hands to make a fist, and you no longer see those nice dips between the MCPs, can be a way of picking up that subtle synovitis in that region. This is obviously some more profoundly affected rheumatoid hands, where you've got this predominant MCP swelling, you've got some subluxation at your MCPs, you're starting to get some early swan necking deformities, and that's what we don't want to see. So this is somebody who's been untreated for many years and has got quite significant deformities in their hands from rheumatoid arthritis, and we're seeing that less and less now. But we do still see it, and obviously we've still got a lot of inherited patients who develop their disease long before we have the good treatments that we do now, who have hands that look like this. Now, I put these slides of osteoarthritis in just to show you, by comparison, how awful osteoarthritic hands can look, and that they can be, quite frightening. And sometimes when people display them, the impression to somebody who hasn't examined many hands with different types of arthritis can be that they've got really, really profound swelling and need to be seen urgently. But actually, this is largely bony swelling. Some of them may be some localized inflammation, but this one on the left-hand side, there's quite a bit of PIP swelling. These are Bouchard's nodes. They've obviously got a bit of CMC joint involvement. You can see the indipping here, where I'm sure they're quite tender. The hand on the right has got a lot of DIP involvement with the Heberden's nodes, and then also some PIP involvement as well. And the writing on here hasn't projected very well, but it's really just to remind people that you get the DIPs, the PIPs, and the first CMC joints. And it's saying here in red, it's pointing to the MCPs, but reminding us that osteoarthritis is much less common there. It tends to be the other joints. So moving on to stiffness in the joints, rheumatoid arthritis causes a lot of stiffness. People will have at least 30 minutes of early morning stiffness usually, and they tell you that their symptoms are better by getting up, moving around, and by the afternoon they feel much better. They're at their best by then. They prefer to keep moving. Whereas people with osteoarthritis may still describe a lot of stiffness on a morning, but it usually tends to be less than 30 minutes. They might say, they're stiff for 5 or 10 minutes. They have to do some stretches to get up. It happens whenever they sit down. And generally their symptoms are worse with movement and worse towards the end of the day. So they prefer to avoid certain activities that bring on their pain. There may be other features that can help you with the diagnosis. So always have a look at the forearms, just near the elbows, for rheumatoid nodules, or they may have rheumatoid arthritis patients may have a lot of systemic symptoms. Fatigue can be very severe. They may have general malaise, low-grade fevers, anorexia, weight loss. These other features are less common in osteoarthritis. So if you've been able to do some blood tests and you've got some antibody results to review, rheumatoid factor tends to be positive in about 60 to 70% of people with rheumatoid arthritis. So a negative result does not mean they don't have rheumatoid arthritis. And CCP antibodies are more specific. So they're about 95% specific for rheumatoid arthritis. They can go up in infection and other conditions, but they're much more specific for RA. Antibodies are usually negative in osteoarthritis, but do remember that about 10% of normal people can carry low levels of rheumatoid factor. So if everything else looks like osteoarthritis and they've got a low level of rheumatoid factor, it probably doesn't mean anything. It's a false positive finding. Well, I think I've missed out one. Sorry, inflammatory markers. So ESR and CRP are usually raised in rheumatoid arthritis. But of course, normal inflammatory markers do not exclude the condition. So just because the ESR and the CRP are normal, if everything else looks like rheumatoid arthritis, please do still refer. OA, the inflammatory markers tend to be normal. If they are up, it might be because of other medical conditions that can also cause a rise in those markers. Have a think about the other medical history. So I've sort of focused on rheumatoid arthritis as the inflammatory arthritis, but of course it could be psoriatic arthritis or gout or IBD associated arthritis. So you have a think about whether there's any history of psoriasis, inflammatory bowel disease like ulcerative colitis or Crohn's, any iritis or uveitis. Psoriatic patients tend to have a lot of tendinopathies and enthesiopathies, so there may be a history of tennis elbow, plantar fasciitis, Achilles tendonitis, and all of those things added together can make you quite suspicious that this is psoriatic arthritis in those patients. Family history, so is there a strong family history of RA or psoriatic arthritis, or is there a lot of osteoarthritis in the family? And joint injuries can help. So if a joint looks particularly severely affected, but it's a ex-rugby player who's injured all of the ligaments in that knee many years ago, they're probably going to get some secondary osteoarthritis developing at an earlier age than you might otherwise expect. Radiologically, the x-rays in rheumatoid arthritis are usually normal in the early stages. There may be a little bit of periarticular osteopenia, so a little bit of bone pulling around the joint edges. Later on, you might see erosions. X-rays in osteoarthritis may show the osteophytes, the joint space being quite narrowed, a little bit of subchondral sclerosis, and then some bony cysts. We often do ultrasound scans of the joints in rheumatoid arthritis. They tend to be more helpful for the small joints, so the joints in the hands and wrists are more likely to show sign of itis than the other joints, and the feet, of course. So you might see positive Doppler signal indicating active inflammation or synovial thickening in the joints. So here's some x-rays. The x-ray on the left is a patient with rheumatoid arthritis showing periarticular osteopenia. This is a slightly more progressed x-ray in rheumatoid arthritis with these marginal erosions showing still with some periarticular osteopenia. And then this is a knee in osteoarthritis. You've got joint space narrowing, you've got osteophytes, you've got subchondral sclerosis. So that's what you're looking for there. And this is just to show you the positive Doppler on ultrasound scan in a patient with rheumatoid arthritis. So when should these patients be referred to secondary care? So we're looking to try and not to miss any of the inflammatory arthritis. So we want to see the patients with rheumatoid arthritis and psoriatic arthritis. We have less to offer, and the patients with osteoarthritis and almost everything that we have to offer can be offered in primary care. So it is trying to differentiate those patients. NICE tell us not to avoid referring urgently anyone with suspected persistent synovitis of undetermined cause, whose blood tests do not show raised ESR or CRP, or where rheumatoid factor is negative, and that's what we've discussed earlier. It doesn't mean refer everyone with joint pain, regardless of what the blood tests show, but it does mean that if you're very suspicious that this is rheumatoid arthritis, don't be put off by normal blood tests. So these cases that I'm just going to run through very quickly are two people that I've actually seen in the last couple of weeks, which is why I decided to present them, just to show how common these situations are. So the first one was a 78-year-old lady. So, you know, before we get into the details, we might be thinking, okay, this is somebody who's a little bit older, perhaps osteoarthritis might be going on. She gives a 3-month history of stiffness and joint pain. So it's relatively new onset. And actually, when you ask her a few more questions, before that, she was really fit and well. She was doing yoga and getting around. And this has been quite a profound onset of pain, such that she was, you know, her walking changed. She wasn't able to do things. She was very stiff on a morning for at least 30 minutes. She initially took a bit of ibuprofen, and that helped a little bit. But due to concerns about using it in her age, she was switched to paracetamol, and that really hasn't helped her at all. She hasn't had any other medical problems in the past and has no family history. Examining her hands didn't look too bad. She had a little bit of mild bilateral wrist and knee swelling, but was tender across her MCPs and also tender in both shoulders. So she's got a symmetrical pattern of joint involvement, so feeling a little bit more suspicious that this perhaps might be inflammatory. Her inflammatory markers are up a little bit. She's got an ESR of 44. It's not hugely elevated, but it's up a bit with the CRP. Rheumatoid factor and CCP are negative though, so I don't know, should we be put off by that? Do we call this osteoarthritis because they're negative? X-rays aren't showing anything either. But she has an ultrasound scan of her hands and wrists, and she's got bilateral wrist synovitis. So I think, you know, she's got sudden onset of joint involvement, she's got stiffness, she's got raised inflammatory markers, she's got a symmetrical pattern and synovitis on an ultrasound scan. So this lady has seronegative rheumatoid arthritis, and we'll start on treatment. The second case, so this is a younger lady, so she's falling in the age range 40 to 60 where rheumatoid arthritis is onset more commonly. She's had various different joint pains for many, many years. Over the last 2 years, things have been getting more severe. Her grip's become poor. She's struggling with activities. She's very stiff. It can last all day. She doesn't really like doing very much at all. But things get worse during the day. By the evening, she's quite bad. Everything that she's done during the day has really exacerbated her joint pains. She's a little bit menopausal. She's got a history of hypothyroidism. Examining her hands, there's a couple of the PIP joints that are a little bit tender, and she's also quite profoundly tender in the first CMC joints, the joints at the base of the thumb. She's got a few supple Heberdens nodes in her DIPs. She's got a lot of crepitus in her knee. She's got a low level of rheumatoid factor, but CCP is negative, and her inflammatory markers are normal. X-rays are more in keeping with degenerative changes in osteoarthritis in both the hands and the knees. Because of her low level rheumatoid factor and her stiffness, she does have an ultrasound scan to make sure that we're not missing anything. There's a bit of mild synovial thickening in the joints, which would be in keeping with osteoarthritis, and there's nothing to suggest active inflammation. There's no positive Doppler flow. So this lady has osteoarthritis. I'm very, very briefly going to move over treatments. So with rheumatoid arthritis, we often treat with combination therapy. They may have NSAIDs before they come to us, or for breakthrough pain and flares. And similarly with steroids, they're used early on in disease because they act quickly, and we want to get on top of their pain and stiffness rapidly whilst we're waiting for the other drugs to work. They can be given as oral tablets, IM injections, or intra-articularly into specific joints if they're flaring. Next level of treatment is DMARD therapy, most commonly with methotrexate, sulfasalazine, hydroxychloroquine, or leflunomide. And if they fail on these treatments and they have highly active disease, which we calculate using a DAS28, which is a combination of number of swollen joints, number of tender joints, ESR, and the patient global assessment of their disease activity. So if that's high, we move on to biologic treatment, which might be with anti-TNF, rituximab, abatacept, tocilizumab, or JAK inhibitors now, which I haven't added to my list. Osteoarthritis, so there's a lot of focus in osteoarthritis on managing patients more conservatively, so talk to them about lifestyle changes, losing weight, exercising more, and exercise should include a combination of stretching, strengthening, and aerobic exercise. Local heat or ice packs to specifically affected joints can be helpful. Splints and supports and proper footwear and walking aids can help. Physiotherapy. So there's a little bit of evidence out there for some supplements such as glucosamine sulfate at the 1500 milligram dose, and then anecdotal evidence and some very minor trial evidence for some of the other supplements, chondroitin and fish oils. And I can't believe that anyone hasn't got a patient who's come in to see them and tell them how amazing turmeric's been for their joints recently. TENS machines and complementary therapies, so acupuncture and osteopaths and things are often found helpful by some patients. I'll move on to medications on the next page, and then obviously, you know, if all else fails, joint surgery, which may be a simple washout of the joint, it might be a joint fusion to reduce the pain and stabilise the joint, or it might be a full joint replacement. So in terms of the medications, anti-inflammatory creams and gels can be quite useful. Capsaicin cream, which is the pepper cream that burns when it goes on. You need to make sure that the patient washes their hands after using it before they touch their eyes or go to the toilet, otherwise it's going to be very uncomfortable. Must be used 3 or 4 times a day for it to work, and usually takes a good 3 or 4 weeks of use before it becomes effective. So it's quite an undertaking for the patients, and there aren't that many people who are keen to persist with it. Paracetamol is the safest if we're going to move on to tablet form, usually at the reduced dose of 3 times a day in the more elderly population. For flares, so if particularly with the hands, the PIPs and DIPs can often have quite an acute flare when the joint is initially becoming affected by the arthritis, and sometimes just a few days or a week of a non-steroidal anti-inflammatory can help to settle that down or get people through particular things that are events that they need to attend. Combination therapy, all the above, can be useful for more severe pain with badly affected joints in people who are at the point of surgery or unable to have surgery. They may move on to opiates, and then intra-articular steroid injections can be used. Less so for the sort of more degenerative bony changes, but when the joint's acutely inflamed, it can be quite helpful, especially to get rid of a lot of fluid on the knee and put a bit of steroid in. Sorry, this is so small. So this is my summary slide of everything that we've discussed before, and if it's useful to you, I can supply that separately, so it can be circulated as a Word document so you can see the information a bit more clearly, but it just summarises exactly what I've said before about the age of onset, speed, which rheumatoid arthritis being symmetrical, which joints are affected, antibodies, inflammatory markers, and other considerations. So I'm happy to supply that to you in a Word document that'll be easier to read. That's everything. So are there any questions?
Thank you very much for that. Yes, we have a few questions lined up in the chat. First of all, is there any guidance for restarting steroid joint injections in primary care? We stopped due to COVID risk and reduced immunity.
Yes, absolutely, I would say. So we've been giving them in secondary care, and we've not seen any particular complications related to COVID. So I think with the correct PPE and distancing procedures in place, there's no reason why that can't be equally safely performed in primary care.
Okay. This is a statement. So my ex-colleague, who is now GPST1 in Yorkshire, is doing joint injection at his surgery. I don't know if there's any comment on that.
Dr. Daniel, this is Situ.
Hi, Situ.
Hi, it's Mohammed actually. He told me about 2 weeks ago that he's doing joint injection at his GP surgery with his supervising GP. So yeah, he just told me that.
Thank you.
So, right.
At what stage of rheumatoid arthritis would you expect to see synovitis on USS?
So ultrasound can pick up synovitis very early on. In fact, even when clinically we aren't able to see anything. So quite low levels of synovitis can be picked up on ultrasound, and it's an early finding. So not like the X-rays, which are more of a late finding.
Okay. And finally, for the moment. So many patients with osteoarthritis will say they have stiffness for more than 30 minutes. Do you have any tips on questions we can ask to differentiate between true stiffness and subjective stiffness of less than 30 minutes?
It's really difficult, actually. Yeah. So the second case that I presented was a lady who said she was stiff all day. So I think sometimes the improvement can be quite helpful. So rheumatoid arthritis patients are much more likely to say to you that they feel a bit better later on in the day or after a few hours. And I think that differentiation between how stiff they are in the morning compared to later can be quite useful for looking at inflammatory arthritis. And then also adding in the questions about the effect of exercise. So, you know, if you were given the choice between sitting in a chair for an hour or being allowed to walk around very gently at your own pace for an hour, which would you find more comfortable? And most rheumatoid arthritis patients would be more likely to say they prefer to just keep moving gently. They can't do things quickly because their joints are very painful and inflamed at that stage, but they prefer to keep moving. Whereas the osteoarthritis patients might say, no, a nice comfortable chair. So it's really difficult, and it's not definite. But sometimes if you're very suspicious, you just ask a few questions to probe around and try and get a feel for where that patient's sitting.
Thank you. One more. Does certain food affect rheumatoid arthritis?
Probably, yes. So there's various trials that have been done, and there are some foods that are considered to be more pro-inflammatory and some foods that are considered to be more anti-inflammatory. Pro-inflammatory foods being the sort of more saturated fats, and sugary content foods, whereas the healthier diet with the unsaturated fats, lots of fresh fruit and vegetables, turmeric being the more sort of anti-inflammatory diet. Some patients will talk about specific foods that tend to flare their joints, so it's often cheese or chocolate or certain alcoholic drinks that they will say for them really do trigger the flares and they avoid them.
Okay. And do you recommend glucosamine?
I recommend people give it a try. So we haven't got that much to offer people, and a lot of people want to try something themselves. They prefer to avoid medications. There is a little bit of trial evidence out there for the glucosamine sulfate rather than the other glucosamines at the 1500 milligram dose. So I say to people that it doesn't work for everybody, but it's worth a try. And if it works for you, then carry on. And if you don't feel it works for you, then by all means try some of the other supplements or just give them all up and try the other alternative methods for controlling the pain.
Could you tell me what is the mechanism of pain in osteoarthritis?
Why do they get pain, did you say?
What is the mechanism of pain?
So it's because the whole joint is affected. So the joint space becomes narrowed, and you effectively, in some, the most severely affected joints, you've got bone rubbing on bone, which creates this localized inflammation. So within the joint, the synovium will become thickened. You can get joint effusions that develop, and this is the whole synovial area is supplied intensely by pain receptors, so they will get pain as a result of that localized inflammation.
Is it because of the synovitis, the inflammation of the synovial, which is causing the pain?
Not just that, because even the patients with purely bony changes and no effusion and no active inflammation in the joint at the time they're seen still have pain.
Thank you.
We've got another question coming on the chat. If a patient is presenting with symptoms of rheumatoid arthritis, but anti-CCP bloods are negative, would you suggest referring to rheumatology anyway?
Yes, so if your clinical suspicion is that it's rheumatoid arthritis on other factors, don't be put off by the blood test being negative, either for CCP, rheumatoid factor, or the inflammatory markers being normal. But equally, if the bloods are very slightly positive, so a low level of rheumatoid factor or a slightly raised inflammatory marker, and it really doesn't sound like an inflammatory arthritis, the clinical impression is one of pure osteoarthritis, don't be swayed by the bloods in that direction either. So the bloods can be helpful, but I wouldn't change your diagnosis on them unless they are profoundly abnormal.
Okay, the questions are piling in now. Would you expect a GP to have requested ultrasound scan before referral, or are blood tests enough?
So blood tests are enough, really. I mean, I don't think I've seen more than, I probably around 1% of the patients I see have had an ultrasound performed before they come through, and I think at this current time it would be almost impossible to get one for the GPs. So the blood tests will be enough. It doesn't mean that there isn't scope to produce a pathway whereby that facility is available to GPs, and we use that as a pathway in the future, but at present that doesn't exist, and I'd rather the patients were seen than delayed.
Okay, thank you. Oh, and here's another one. Would you, oh, no, that's it. Are there any other questions on this presentation? No, I think that's all the questions we have. Dr. Daniels, thank you very much. That was a brilliant presentation. Obviously very well received as Dr. Lynn's. We will now hand over to Dr. Rousseau.
Hello, everybody. So this is a presentation that a GP trainee has prepared some years ago. He was a very enthusiastic doctor. He wanted to learn everything in rheumatology in a simple way. And because this subject of autoimmune diseases is rather complicated, I thought what he has put down was probably enough. And from what I heard before, there may be some overlaps, but hopefully it will sort of fit together. So we're going to present what is what, how to clinically divide the arthritis, what is happening with rheumatoid factor and anti-CCP, the rest of the antibodies, then, okay, bloods are bad, so what? Treating the patient, DAS28 score, and about disease-modifying antirheumatic drugs and biologics. This GP made separations according to how he realized things are working. So he has actually divided the people and the diseases as loners and groupies. So he put down the monoarthritis in a list with septic arthritis, crystal arthropathy, osteoarthritis, trauma-related arthritis. After a trauma, people develop osteoarthritis after around 10 years or more. The oligoarthritis group, which has crystal arthropathy, psoriatic reactive arthritis, ankylosing spondylitis, and osteoarthritis. Then in the polyarthritis group, he has divided symmetrical and asymmetrical, with symmetrical having rheumatoid osteoarthritis and the asymmetrical has reactive arthritis psoriatic. In this group, he also included the systemic conditions such as lupus, sarcoidosis, hemochromatosis, sickle cell disease, familiar Mediterranean fever, Behçet's disease. Then he realized that actually there are more. So he divided inflammatory versus degenerative versus infections. He also took into consideration the timing, so he divided acute versus chronic, and if there is any previous history such as psoriasis or trauma. With regards to rheumatoid arthritis, you have already heard that is rheumatoid factor and anti-CCP antibodies. Rheumatoid factor is less specific than anti-CCP. It can also be seen positive in Sjogren syndrome, in Felke syndrome, and it can found in a percentage of normal population between 5 and 10%. Those who are positive for rheumatoid factor and or anti-CCP, they are called seropositive patients or seropositive arthritis. A bit more about rheumatoid factor, and because there was already a bit a presentation before, I'm going to run through quickly. It's an IgG antibody against an IgM antigen. It's very non-specific. 40% of seropositive patients, of those ones who eventually we develop seropositivity, can have positive rheumatoid factor in the early stages of the disease. And some 80% they can have later in the disease. Disease-modifying anti-rheumatic drugs can contribute and make a seropositive patient seronegative. Anti-CCP antibodies can be present earlier in the disease course. Sometimes their presence can precede rheumatoid factor by many years. Also, rheumatoid factor can be found positive in some infections. This is due to cross-reactivity. Hepatitis C, for example, patients who are suffering with hepatitis C may have rheumatoid factor in their body. And those people, because hepatitis C can also present with arthralgia, we have to distinguish that what is the case? Is it the hepatitis that mimics rheumatoid arthritis, or it is rheumatoid arthritis with hepatitis? IE stands for infective endocarditis. Osteomyelitis can have a positive rheumatoid factor. And he then thought that we check for hepatitis B and C for rheumatoid factor, but it's not only that. We do check for hepatitis B and C because we want to make sure that people are not infected, as most of our drugs, nearly all of our drugs, are hepatotoxic. Rheumatoid factor can be seen in other connective tissue diseases. Therefore, antinuclear antibodies and extractable nuclear antibodies need to be done. This is a graph which indicates that the higher the rheumatoid factor, the more severe the disease is. We do see levels that drop with the drop of the disease activity. Rheumatoid factor levels don't change with the age. Another interesting graph. Connective tissue antibodies. This is the main purpose of the talk. What are these and what do they mean? ANA stands for antinuclear antibodies. patients who have positive antinuclear antibodies usually have a connective tissue disease. I'm saying usually, well, always have. The question is how serious this may be and how treatable this may be. Low titers of antinuclear antibodies are most of the times of no clinical significance. If the titers are higher, if they are strongly positive, they do indicate some significance. When we identify patients with positive ANA, it's very important to see the pattern of these antibodies because they may again indicate disease. When we see ANA positive, the next step is to check for ENA and double-stranded DNA. So what are the ENAs? ENA stands for extractable nuclear antibodies. These are the anti-Rho and anti-La, which we usually see in Sjogren's syndrome. However, either of the two, we can see them in lupus, or there may be patients with rheumatoid arthritis who have overlap with other autoimmune diseases, such as Sjogren's. It could be secondary Sjogren's from rheumatoid arthritis, or could be Sjogren's with positive rheumatoid factor. The difference between Sjogren's and rheumatoid arthritis is that Sjogren's syndrome is a systemic disease but does not do erosions in the joints. Patients have joint pains, but this pain does not underline joint damage and does not progress into joint erosions. Anti-Smith antibodies, they are seen in lupus. RMP, ribonuclear protein, anti-ribonuclear protein antibodies indicate mixed connective tissue disease. Mixed connective tissue disease does not mean a bit of everything. It means it is a specific condition. Usually it's a prodromal condition. It appears and we are watching the patient in case the patient will progress to either lupus or scleroderma or dermatomyositis. Anti-Jaw antibodies, we see them in polymyositis and dermatomyositis. And the SCL70, we see them in systemic sclerosis. This is a graphic representation which I kept because I thought it actually includes everything. So if ANA is negative, there is no need for ENA screen. If ANA are positive, then we ask for those for ENA, and depending on what the outcome will be, patients may have Sjogren's, lupus, mixed connective tissue disease, polymyositis, or scleroderma. The patterns could be homogeneous, speckled, nucleolar, or centromere. And further down, we will talk about this in more detail. So this is how they look. Homogeneous is on the left, nucleoral, which we see in systemic sclerosis below that. Centromere, we see this in scleroderma and speckled in the mixed connective tissue disease. Next, please. So in the SLE, the typical serology is ANA positive with homogeneous pattern, and from those SLE patients positive for ANA, only 15% have lupus, because ANA positivity does not necessarily mean lupus. It can be patients may have Hashimoto's thyroiditis, for example, which is again an ANA antibody, and we don't treat it. When we find antihistone antibodies in the blood, it indicates that there is drug-induced lupus. Double-stranded DNA with ANA positivity means lupus, which again, if for someone to have lupus, apart from ANA, double-stranded DNA, need to have other findings from either organs or from the blood. For example, lupus is characterized by low lymphocytes. If a patient has anemia, maybe something from the skin, not necessarily, may have systemic symptoms like headaches, photosensitivity, and ANA positive, double-stranded DNA positive, then we think about lupus. I'm not talking about lupus nephritis, which clearly it's a very, very serious condition, in which case we have to check the urine, for example, and we are looking for protein in the urine. The complement C3 and C4, it is of importance and significance if it is low. If it is elevated, it does not mean anything, and it is not dangerous. Scleroderma can be either limited or systemic. The pattern could be ENA positive and could be either centromere, which indicates crest. Crest stands for calcinosis, rhinoesophagitis, sclerodactyly, and telangiectasia, or on the SCL70, which is the diffuse and systemic disease. Very briefly, I'm not supposed to talk about vasculitis, but because the GP trainee thought he wanted to have a full picture, he made this slide, and I kept it for you. So basically, in vasculitis, patients have ANCA positive, and this can be, ANCA stands for anti-neutrophil cytoplasmic antibodies. This can be positive. It can be P-ANCA or C-ANCA. C-ANCA or ER3 is seen in Weger's granulomatosis. It's a medium vessel disease. It affects nose, lungs, kidneys. P-ANCA is, or MPO, it is related with microscopic polyangiitis, and it affects small vessels. Both can be very serious and can be dangerous for the kidneys. Next, please. The GP trainee wanted to learn all about antibodies, so we went through some important ones and the clinical significance of them. So with regards to gastroenterology departments, antimitochondrial antibodies are related to primary biliary cirrhosis, mostly 95%, and 30% with autoimmune hepatitis. Anti-smooth muscle antibodies, mostly autoimmune hepatitis, to a lesser extent primary biliary cirrhosis. Antigliadin and endomysial and tissue transglutaminase are related to celiac disease. Gastric parietal and intrinsic factor antibodies are related to pernicious anemia. Related to endocrine system, thyroid peroxidase antibody positive are mostly related to Hashimoto's thyroiditis and to a lesser extent to Graves' disease, while glutamic acid carboxylase GAT antibodies are related to diabetes. These positive antibodies can also be associated with the stiff man syndrome. And antiglomerular basement membrane related to good pastures and has 100% sensitivity. Next, please. This is a schematic of rheumatoid arthritis. If you look at the x-rays, there are erosions, there is no joint space. And on the left schematically is the ulnar deviation, the subluxation of the wrist, swan neck deformity, and boutonnieres. Next slide, please. So very briefly, because you heard about that, when we see a patient with rheumatoid, which is a erosive disease, inflammatory symmetrical polyarthritis with systemic involvement, we need 4 out of 7 criteria in order to put a diagnosis. This is morning stiffness, 1 hour for more than 6 weeks, symmetry, nodules, X-ray changes, more than 3 joints, joints of the hands, and rheumatoid factor. In addition, we look for other symptoms like lethargy, serositis, such as pericarditis and pleurisy, weight loss, fever, atherosclerosis. Lung nodules may have, or people with rheumatoid can present as polymyalgia rheumatica. So can be a polymyalgia rheumatica as a first presentation that progresses. The clinical assessment of the patient is the DAS28 score, which means that there are 28 joints that are assessed for tenderness and novitis. And the differential will be psoriatic arthritis, ankylosing spondylitis, and SLE, of course. Next. These are the blood tests that you have heard earlier on, what blood tests and X-rays are needed. Next. This is how the DAS28 is used. I don't think I will go into these details, but you can have the slide and review it if you like at a later stage. Next, please. This is the mannequin of tender and swollen joints. Next, please. With regards to disease-modifying antirheumatic drugs, otherwise called DMARDs, they are not simple analgesia. They are given to stop the disease to progress with the aim to prevent joint erosion. They can be very toxic. We usually start them on this medication and then we try to follow them up. Next, please. These are the drugs that are used as first line. The other name is conventional synthetic DMARDs. Hydroxychloroquine is a mild one. It's an antimalarial. It does not need a regular blood test. What it needs is yearly eye test. However, the macular disease that it is the side effect from the long-term use of hydroxychloroquine can be seen after 5 years of daily use. Methotrexate is the first drug we use. It is quite cheap. It is given with folic acid. It can be hepatotoxic and it can be myelosuppressive. We watch the patients. Usually the liver tolerates it well, and the marrow. When they develop a degree of hair loss, which however it's very apparent for the first 3-4 months, and subsequently stops and becomes less. And when the medicine discontinues for any reason, the hair comes back. Leflunomide, it's a potent drug. We need to watch the patients again. Similar with methotrexate, more expensive than methotrexate. Gold is not used any longer. Sulfasalazine is used, and it has a role to play in seronegative arthropathies, mostly. Relatively well tolerated, but it can induce allergic reactions and it can affect the marrow. Next. Other frequently used drugs, azathioprine, cyclosporin, cyclophosphamide, MMF, and tacrolimus. Next. So the biologics. As I said, this presentation was done by a GP trainee, and he was trying to understand what we were talking about. So empirically, he said, okay, if it is a drug that finishes in MAB, it is a monoclonal antibody. They are expensive, although now with biosimilars, the price has fallen. There are some guidelines. Patients need to have a DAS28 of more than 5.1 to qualify for biologic. Usually they are given by injections or infusions. Right now we have the JAK inhibitors like tofacitinib, baricitinib, filgotinib that are given by mouth. Next. These are the groups with the names. I don't know if there is any point for me to talk about them in an analytical manner. I can skip to the next slide, and if anybody has any question around any of these drugs, then you can ask and I can answer. Next, please. So, in summary, the first is to identify the disease clinically, then screen serologically, so we can have a baseline assessment, then commence appropriate therapy, review, and step up or down as necessary. As I said, this is rheumatology made easy by a GP trainee addressed to GPs. So that is what he understood, and I thought it would be useful for me to share this with you. Thank you for your attention, and I'm happy to answer any questions.
Thank you very much for that. Okay, so we don't have any questions in the chat. Does anyone have any questions they might want to pose directly?
Could you tell me, how do you choose which patient is suitable for certain medication?
Well, depends on the depends on the age, on the circumstances, on the plans. For example, if it's somebody who is a young woman who is aiming to have a family and to conceive, then we will choose either hydroxychloroquine or sulfasalazine or both. If it is, usually we start with methotrexate because although it is chemotherapy drug and it is toxic drug, we use it for so many years that we know how to use it. We know what to expect. We know where to stop, to step up, step down. So, but we will not start methotrexate on a young lady, for example, who comes and says, I just got married, I want to have children. Or somebody who developed following the, say, birth of her first child and she would like to have more. So it depends.
We used to do the blood test for the methotrexate every 3 months. Now, for the last few months or sometime, they advise to have it done every month. Is there any reason?
We used to have a guidelines every 2 weeks for 6 weeks, then monthly for 3 months, then 3 monthly. So we don't do very often, but because methotrexate is prescribed by the GPs, and GPs feel more confident to have a blood test every month so that they can check what is happening. But we recommend, very often we recommend less often, like, you know, you can check every 2 months or every 3 months, particularly for patients who have been on a medication for long.
Thank you.
Thank you. Any other questions, comments, or observations?
Okay, thank you very much. If there is any question, people can email me maybe.
Thank you very much for that, Dr. Russo. Okay, so Dr. Daniels.
Hi, can I just check?
We're handing back over to you now.
Can you hear me?
Very faint. I think your audio has gone down a little bit.
Let me just, is that better?
No.
It's when I came off and came back on, I couldn't sort it out. Okay,
Oh.
Can you hear me now?
Perfect.
Yeah, okay. So, sorry, just gonna open my presentation. Okay, so I'm just going to talk to you briefly about gout, and I'm going to try and provide some basic information to allow for the management of acute and chronic gout in primary care, and also to discuss when referral on secondary care might be necessary for these patients. I'm going to start by outlining the epidemiology and pathophysiology of gout, look at the diagnosis and how that can be made, then talk about the treatment of acute gout, long-term management, and I will briefly touch on hyperuricemia because I was asked to when preparing this talk. So gout is incredibly common. It's the most common cause of inflammatory arthritis. So in my previous talk, I said osteoarthritis was the most common arthritis, but of the inflammatory arthritides, gout is the most common one. There was a recent paper published which estimated over 41 million cases worldwide, and that prevalence has increased since the last study date in 1990, globally by 7%, and Western Europe, for which we're included, by over 10%, nearly 11%. The incidence is around 100 in 100,000 people. So what causes gout? So gout is caused when there's a buildup of uric acid in the body, and that's usually because not enough is filtered by the kidneys. 90% of uric acid is filtered by the kidneys. And when that filtration is reduced, there's increased uric acid build-up in the body. There is a genetic contribution to the urate anion transporters, but that only accounts for a small amount. Increased cellular turnover, so in conditions such as myeloproliferative and lymphoproliferative disorders, psoriasis, or when we're using cytotoxics, you can get increased cellular turnover, increased cell breakdown, and that can lead to gout. Single gene disorders being responsible for gout are very rare. You then get a buildup of uric acid, as I said, and the sustained hyperuricemia in the body will begin to lead to the deposition of these monosodium urate crystals in the joints and in other tissues in the body. So this is just having a little look at the pathway in diagrammatic form. So we've got the breakdown of our nucleic acids in the liver to produce purines, which are then converted into uric acid, which is excreted primarily in the kidneys, but also in the gut. Having a little look at the urate crystals in the joint. So here you can see the urate crystals build up initially on the cartilage in the joint. And here on the right-hand side where I'm pointing, you can see that those urate crystals have started on the cartilage. They've built up to a greater extent. And when anything promotes those crystals breaking off from their attachment to the cartilage and being released into the synovium, that's when you get an acute attack of gout in the joint. So the clinical manifestations of having a high uric acid level are that you may get an acute arthritis, so acute gout. You can get bursitis, cellulitis. Over time, those crystals build up and you can get the development of tophi in multiple areas in the body. People can develop a chronic arthritis when they've had prolonged hyperuricemia for many years. You can get kidney disease and you can get renal stones, kidney stones. There's many risk factors for gout. So age and male sex are some of the most common ones, renal impairment and high blood pressure. And in fact, any of the features of the metabolic syndrome are more common in people with gout. So diabetes, hyperlipidemia, hypertension. Diet is contributory. Diets that are rich in red meat, sugary drinks, offal, seafood, or with excess alcohol, particularly the beers and spirits, are more likely to suffer from gout. Weight is a big factor, and as are some medications, so in particular diuretics, but also ACE inhibitors, aspirin, can all increase the risk of somebody suffering from gout. In a patient with hyperuricemia or previous attacks of gout, there are certain things that can trigger an acute attack. So they might be fine for many years and then something happens and their gout flares up. And that can be that they become unwell. So any illness, particularly with a fever, they might go on a binge, be it dietary or alcohol. Get very dehydrated, which can happen on flights or during inpatient stays, any injury to the joint, surgery, or the addition of new medications. And this is the classic gout affecting the first MTP joint. So this is the most commonly affected joint affected by gout, but by no means the only joint. So patients will often describe very sudden onset of pain. It often happens overnight and it peaks within 24 hours. So they don't very often give a history of pain for a long time. It comes on quite acutely. It gets very intense very quickly and will last for 3 to 7 days. The joint is red, hot, swollen, and exquisitely painful to the point that they can't bear anything to touch the joint, including often the bedclothes, the duvet. As I said, the first MTP joint is the most commonly affected, but other joints, the ankle, knee, wrist, elbow, hands, may be affected. We don't see gout in the shoulder very often, or the hip. So here's a person who's got gout affecting the mid joints in their feet. Here's a knee. So investigations are probably not needed to make the diagnosis of acute gout. You can usually make the diagnosis based on the history, but you will need some blood tests in order to be able to support that diagnosis and advise on treatment going forwards. So as a bare minimum, they would need a full blood count, kidney function, liver function, ESR and CRP, and a urate level. I've put urate in brackets because it's not usually recommended to check that during the acute attack because it may be normal at that time. It's not always as obvious as the cases I've described. So if there's any doubt about the diagnosis, there may be additional blood tests that might be needed to help come to the right diagnosis. So rheumatoid factor and CCP, if you're worried, if they've got a few joints affected and you're worried they may have rheumatoid arthritis, bone profile, just to check there's no hypercalcemia or anything that may be causing pseudo gout. Cholesterol and lipids I've added because it's very important to look at their other risk factors for cardiovascular disease because a lot of these patients may have metabolic syndrome. You might want to get an X-ray of the joint. Unlikely that synovial fluid examination is going to happen in primary care. I appreciate the limitations on that happening, but within secondary care, we would try to get fluid from the joint, both to enable the diagnosis of gout by seeing the urate crystals, but also to exclude a septic joint in many cases once they're in hospital. Ultrasound can be used, but it's not often needed. You may wish to consider some genetic screening for HLA-B 5801 in at-risk populations. So this is in terms of being at risk from the side effects of allopurinol, and that's the Han Chinese, Thai and Korean populations in particular. So treatment of the acute attack is treat as early as possible. The patient's going to want you to, they're in extreme pain. Conservative measures, ice, rest, elevation, and a bed cage to keep the duvet off them. An anti-inflammatory, so whether that's a non-steroidal anti-inflammatory or a COX-2, together with PPI protection. Or alternatively, colchicine. We would usually use 500 micrograms BD. You can use up to QDS, but they may well develop diarrhea at that dose. And then if neither of those options are available or tolerated or effective, corticosteroids can be helpful. And again, that can be tablets, injection into the joint, an intramuscular injection, or rarely an intravenous injection. We had a bit of a chat in one of our meetings about starting allopurinol during an acute attack the other day. And whilst it sometimes is done in secondary care because we want to catch that patient whilst we've got them and make sure they're started on treatment, and we know we're giving them adequate painkillers and analgesia that we're not going to make things worse by starting allopurinol. Generally in primary care, if you've got the opportunity to see the patient again, it's better to treat the acute attack, get the tests performed, and then bring them back to discuss things when they're a little bit better able to follow the instructions and listen to what needs to happen when they're not in so much pain. The other important thing to note is that although we say don't start it during the acute attack, it shouldn't be stopped during subsequent acute attacks. So once they're on allopurinol, provided they tolerate it, they stay on it. There are other treatments available for acute attack, not NICE approved. I've mentioned them just so that you're aware that they exist, but I'm not planning on going over them in any depth. So that's things like anakinra, canakinumab, and rilonacept. So the reason we're treating these patients once the acute attack has passed is to prevent chronic arthritis or chronic tophaceous gout. So this is an example of what can happen, and I'm really sorry to say that we do still see patients presenting with hands that look like this and often worse. So there is still a huge amount of undertreated gout, and that is often because the patients may come during the first couple of attacks, but once they know what it is, they tend to manage it at home a little bit, perhaps don't go back to see their GP, or they may see a different GP and they don't get the continuity of care. And things can trundle on for many years with these, resolving acute attacks and gradually worsening joint disease until somebody sees them and sends them through to us. We have a look for tophi. They can be almost anywhere. Fingers are quite a common area. In the elbow, they may have tophi or a chronic bursitis. Tophi in the ear, in the pinna, are quite common. So I've shown that they can be fairly obvious on the left, where you can see a few of them, or they can be very subtle. So on the right, this patient's just got one small tophus in the ear that may easily have been missed if it wasn't looked for. In terms of the long-term management, there are general principles about patient education, so advising them of the need for treatment, talking to them about losing weight, modifying their diet, reducing their alcohol intake, have a look at their medications. If they're on diuretics, do they need to be? Can it be switched to anything else? And really importantly, looking at their other cardiovascular risk factors. So is their hypertension well controlled? Is their cholesterol treated? Is there anything else that they need to prevent future heart attacks or strokes? And then they need to go on something to reduce that very high uric acid level, which is driving the disease. And the most common first-line treatment would be allopurinol, which is a xanthine oxidase inhibitor. So the dose is started low, 50 to 100 milligrams, and can be increased every 4 to 6 weeks by 50 to 100 milligrams. Aiming for a serum uric acid level less than 300. So these patients will often have a level 4, 5, 600, sometimes much higher. And we're aiming to get it below 300 in order to allow the crystals and the tophi to be resorbed and the gout prevented, or further attacks of gout prevented, and then the long-term tophi cleared. The maximum dose of allopurinol is 900 milligrams. Not many people get to that dose because we get their uric acid level adequately controlled at a lower dose, or they stop tolerating the drug at higher doses. Side effects from allopurinol are rare, but they can be very serious. So we do need to be aware of them and look out for them. And that's the reason for starting with a lower dose. So generally speaking, the side effects occur early in treatment and when higher doses are used initially, and they're more common in people with renal dysfunction. So I will come to that in a moment with some guidelines on how to reduce the dose in those patients. So we're particularly looking at skin hypersensitivity reactions, toxic epidermal necrolysis, DRESS syndrome, and Stevens-Johnson syndrome. So it's worth being aware of these. I will often give patients a form to just check their FBC and UNE after a couple of weeks of treatment, before then rechecking their urate level after 4 to 6 weeks of treatment to enable me to guide them on whether we need to increase their allopurinol. So if they have renal dysfunction, we can still use allopurinol, and it can be used safely at very low levels of EGFR. And this very useful table is available on the BSR gout guidelines, which have been published. So even with a EGFR between 16 and 30, you can still start allopurinol at the reduced dose of 50 milligrams every 2 days. With an EGFR 5 to 15, you might give them 50 milligrams twice weekly. And there's even a guide for an EGFR under 5 of just using a single 50 milligram dose once a week. And you would then more cautiously increase the dose. So you're still aiming for a serum target, a target serum uric acid level of less than 300. The target remains the same, but you start lower and you increase more slowly and more cautiously. When we start patients on allopurinol, on urate lowering treatment, they can suffer acute attacks of gout in the early weeks and initial stages of treatment. And that's as we're removing the uric acid from the joints. Some can escape into the joints and cause acute attacks. And so we would usually give patients prophylaxis to prevent those acute attacks, because otherwise they associate them with the allopurinol and they're not keen to take it and they discontinue it. And then we see the joints that I showed earlier when they eventually come back many years later. So prophylaxis could be a small dose of colchicine, 500 micrograms once or twice a day. It could be a non-steroidal anti-inflammatory or COX-2 with a PPI. Very rarely, if patients are suffering a lot of acute attacks and they can't tolerate those, we'll put them on some steroids with a PPI just until we get things a bit better controlled. If your patient is unable to tolerate allopurinol, the alternative that's easily available is febuxostat. The dosing here is more simple, so 80 milligrams once daily can be used safely in anyone with an EGFR over 30. And if they continue to have a serum uric acid level above 300 after 4 to 6 weeks, you increase the dose to 120 milligrams once daily. And that's it. There's just 2 doses, 80 increasing to 120. There are other treatment options available should allopurinol and febuxostat fail. I don't think these are used readily in primary care, so I wasn't planning on spending a lot of time on them, but just to make you aware that they exist. So these are agents that increase the urinary excretion of uric acid, such as sulfamyrazone, probenecid, benzbromarone, some of which are only available on a named patient basis. So that's going to be through secondary care. And then pegloticase and rasburicase, just to be aware that they exist. So I just thought I'd mention adjuvant therapies. So these are by no means sufficient to treat gout, but if you are looking to treat hypertension in your patient who suffers from gout, you may wish to consider using losartan, and similarly for elevated lipids, you may wish to consider fenofibrate because they do have mild uricosuric activity, so they can slightly reduce the uric acid levels, but not enough to be the primary treatment for gout. And similarly, consider the addition of vitamin C between 500 and 1500 milligrams daily. So I've mentioned this number a few times, but I'll just mention it again to make sure it's really firmly lodged in everyone's minds. We're aiming for a serum uric acid level of less than 300. And once that level has reached and the patient has no further attacks and their tophi have all resolved, which can take many, many years, you can then consider being a little bit less strict with the uric acid level and looking for one between 300 and 360 millimoles per litre. So you can slightly ease back on their treatment with that new target in place. And treatment should be lifelong. So you don't treat until their gout goes away and then stop. You treat to normalize their uric acid level, and then you continue lifelong so they don't get further attacks of gout, unless something dramatically changes in the patient that makes you think they could do without treatment. So very, very significant weight loss, becoming a teetotaler after being a heavy drinker. Those are sorts of big changes that might enable you to stop treatment, but there's very few other changes that would suffice to avoid medication. So I've just got one slide on asymptomatic hyperuricemia. So I think my first question is it truly asymptomatic? Because my feeling is that in most cases, if you've got to the point of checking a uric acid level, it's because the patient has had some joint symptoms or renal stones or another reason to check it. The really important thing is if they do have hyperuricemia is to address their other cardiovascular risk factors. Think about what the level is. So, you know, we certainly, if it was done as a very, very random test in a patient with absolutely no symptoms, we're certainly not going to be treating that patient without gout. But if there was a very, very high level of uric acid level, you might want to have a little bit of a think about what that is, some careful observation, or maybe discuss with one of the rheumatologists. So is secondary care referral needed? I think if the diagnosis isn't clear, so if you're not certain about the diagnosis, you might wish to consider referral or communication. If the patient is intolerant to or fails to respond to the maximum dose or maximum tolerated dose of allopurinol or febuxostat, if the patient has quite severe renal impairment and you're not comfortable managing that in primary care, that's a reason to refer in. Or if they've reached the stage of developing chronic tophaceous disease, then you're probably going to need secondary care involvement. So just to summarize very briefly, treat the acute attack rapidly with non-steroidals, colchicine or steroids. Have a low threshold for initiating urate lowering therapy. So that might be 2 or more attacks of gout, or 1 attack in somebody with an extremely high uric acid level and other risk factors for further attacks. Start with allopurinol 50 to 100 milligrams, titrate in 50 to 100 milligram increments to a maximum dose of 900. Adjust that according to their eGFR, and you can use the table in the BSR guidelines. Consider febuxostat as an alternative. It's 80 milligrams increasing to 120. Your last time I'll say it, serum uric acid level target is less than 300 micromoles per litre. And you should be, sorry, my TV is about to turn off. You should be, I'm so sorry, I just lost everybody. And then you should be offering prophylaxis when urate lowering treatment is started with colchicine or a non-steroidal. So thank you for listening. And are there any questions?
Thank you for that. Yes, there are quite a few questions in the chat. Let's go back to the beginning. So how often do you need to monitor uric acid levels?
So when you're initially treating the patient, you would be repeating it at 4 to 6 weekly intervals until you reach your target. Once you've reached your target and the patient is stable and you're no longer titrating the dose of your medication, then once every 6 to 12 months is sufficient, probably once every 12 months, maybe more often if there's other risk factors. Yeah.
Okay. Does gout occur in children?
Not commonly, but I think it can. I don't treat children, but I believe it. I believe it can in the single genetic the conditions I talked about, where you have a sort of single gene defect, so those children can develop gout. Okay.
What happens when urates are normal in gout?
So if the patient definitely had gout and they previously had a high uric acid level and you have normalized that level with treatment, but they're still having attacks of gout, it may be because there's still an awful lot of uric acid crystals and tophi in the body, so they're still getting acute attacks whilst you're waiting for resolution of that collection of tophi and uric acid crystals. If you think they've got gout, but their uric acid level has always been less than 300, it's probably not gout.
Oh. Okay, next question. Do you have any specific choice for non-steroidal?
I tend to use naproxen, 500 milligrams BD. You can use ibuprofen. Indomethacin is quite commonly used in gout. And then COX-2 inhibitors like atoracoxib can be useful for patients with more sort of who don't tolerate non-steroidals if they've got a few GI risk factors.
Okay. There are quite a few lined up here actually, so I'll just let you know that. Do we need to cover with non-steroidals for febuxostat and for how long? Febuxostat and for how long?
Yes, so you cover with allopurinol or febuxostat with prophylaxis, either with non-steroidals or colchicine, and it's so there's no definite time period set in stone. So I would usually say as long as you're titrating the therapy. So if you're titrating every 4 to 6 weeks, you probably need to keep them on some prophylaxis at least until you get the uric acid level almost normal. There's some talk about sort of 6 to 12 months, but I guess that coincides with when you hope you would reach your target if you're actively titrating the drugs every 4 to 6 weeks.
Okay. Is allopurinol, I can't pronounce that, sorry, I heard you say it a few times. Is it for life? Can we stop as a trial after 1 year? Why is it not recommended to repeat colchicine course within 3 days?
So allopurinol is for life as long as they are tolerating the drug. Maybe at a slightly lower level if they've been gout-free for some time with no tophi, with that slightly more relaxed target uric acid level that I mentioned of 360 rather than 300. We wouldn't normally stop after a year. That's, first of all, probably a bit too soon. And secondly, it depends. So we wouldn't normally stop after a year. It's lifelong. As I said before, if the patient has made some really major lifestyle changes and their uric acid level is extremely low and they've had no acute attacks of gout, then weaning them off and stopping treatment is an option. But it's very, very rare that you see patients making such huge changes to their life that they don't need the allopurinol later on. And the colchicine question, we don't really follow what BNF says for colchicine. I think it says give them a really high dose until they get diarrhea and then stop it after a couple of days. We don't really use it that way at all. We tend to use 500 micrograms BD, sometimes reduced to once daily if they've got a bit of renal impairment, and then continue it long term as prophylaxis.
Okay. Any CL to colchicine age cutoff?
Any what, sorry?
It's CI or CL?
Oh, contraindications.
CIs.
Severe renal impairment, you have to be a little bit careful. You can still use at a reduced frequency, perhaps giving just a couple of times a week or once a week, but you do have to reduce the dose. Some people have hypersensitivity reactions. You can develop side effects to the drug and then you wouldn't use it again. And I've forgotten what the other part of the question was, sorry.
Age cutoff.
Oh, no, not really, no.
Okay. If we suspect gout, would we send them for urate levels during acute attack or wait for the attack to settle and then aim to get their target to 300?
So if you're doing bloods anyway, you can do their uric acid level, and if it's elevated, then and you clinically think you've got the right diagnosis, then you're fine. But it can be normal during an acute attack. It's a strange anomaly. So if it is normal and you were very suspicious, you'd want to repeat.
Okay. Where have we gone? If allopurinol is lifelong, once uric acid is within range and corrected, do you keep them at the same dose?
So you can try reducing as long as it's within range, but you would want to keep them within the range that you're looking for. And you wouldn't start reducing the dose if they're still having any attacks of gout or they still have any tophi.
Okay. How long after their attack do we start allopurinol? It says, is it a question of clinical judgment?
As soon as they're able to have that discussion with you in a sort of pain-free fashion and understand the dosing and the monitoring.
And one for your scrapbook. We've got one child with gout.
Thank you.
Next question: do we have to check GFR regularly? If so, how often if they are on allopurinol?
So I would do it if they're not having bloods for any other reason. I would do it 6 to 12 monthly with their uric acid level. So I would do all of their bloods at that time once they're on stable treatment. If you're titrating the treatment, I would do it with each blood test before titrating treatment.
Okay. When a patient has a gout attack, how long do you stop allopurinol for?
You don't stop allopurinol during acute attacks of gout. You don't always start it during the first acute attack, but you don't stop it during subsequent acute attacks.
Okay, and final one for from the chat for now. I believe current guidelines. So I believe current guidance is to start prophylaxis after just one attack. Do you agree?
I do. So I think they will almost inevitably have another attack. They've got a high uric acid level. They've probably got lots of risk factors. If So I think there will be exceptions. So there may be somebody who has a few contraindications to the drug and had a clear event that precipitated it, maybe became very unwell, had surgery and started on some drugs at the time, which could subsequently be stopped. So there are examples where the circumstances around that single acute attack mean that it's less likely to happen again and the risks of treatment are higher. But for most people, the risks of treatment are low. The risks of not treating them are very high in terms of the joint damage and the tophi. And I think they almost certainly will have another attack of gout at some point. And if you've got the opportunity, you've got them there, it would be better to get them started on treatment than wait for them to go away and start managing the gout themselves with over-the-counter ibuprofen and not come back to you.
Okay. Oh, sorry, jumping all over the place now. So I think you might have covered this, but if they have a flare up on allopurinol, would you increase allopurinol once they are pain-free? And it's an excellent presentation.
Thank you. So I would if their serum uric acid level was above 300. So once their serum uric acid level is below 300, I don't think there's any evidence for increasing the allopurinol further and aiming for an even lower level, because you've got your level below the level at which uric acid saturates. But again, don't be guided by what the uric acid level is during the acute attack. Wait until it settles, recheck it, and if it's elevated at that stage, increase the dose.
Brilliant.
Can I ask you one thing? I know I did that. Can you get a gout without having an increase in the urate level?
Can you have gout without an increase in the uric acid level?
Uric acid, yeah.
So
we see them with a gout clinically there, do a blood test, and it comes out with normal.
Yeah. So as I was trying to say earlier, if they're already on treatment, and you've brought their uric acid level down from previously being very high to now being normal, they can continue to have episodes of acute gout. Or it may be that you're checking their uric acid level during an acute attack of gout and it's coming out as low. But if they've never been on treatment for their gout and you're checking the bloods at a time when they don't have an acutely inflamed joint and the uric acid level is still low, still below 300, then it's probably not gout. And I would think about other things. It could be pseudo gout. So if they've got a bit of underlying osteoarthritis, it could be pseudo gout, or it could be another type of inflammatory arthritis.
Thank you.
Okay, lots of very positive comments and feedback about the presentation and a request for the slides to be shared.
No problem.
And I think that's a comment to all of our presenters. There have been lots of very good positive feedback about all the presentations and requests for the slides to be shared. Any final questions before we hand over to our next presenter? Okay, well, thank you very much for another great presentation.
Thank you. Thanks for listening.
I will now hand over to Dr. Doherty.
Hello, can you hear me?
Yes, we can.
Great, okay.
Your slides are up.
Thank you for the invitation for us to come and talk with you. And I'm going to give a talk on inflammatory back pain mainly and how you might approach it in primary care. So here we go. So I'm going to cover chronic back pain, and you'll see why I think that is important. Inflammatory back pain. Focus on the spondyloarthropathies, which are the axial spondyloarthritis and non-radiographic spondyloarthritis and its associations, the diagnosis and some of the treatments. So chronic back pain is any back pain that's been present for 3 or more months. It's important with regard to inflammatory back pain in less than 45-year-olds. That's the group we're most interested in capturing. It's very common, as you know, in primary care, and it's very common between the ages of 25 and 44. At some stage in their life, 41% of females will complain of 1 month of back pain, and 36% of males. So ankylosing spondylitis and the other spondyloarthropathies will account for 5% of chronic back pain in primary care settings. That's very important. So with regard to inflammatory back pain, up to 14% of patients who have inflammatory back pain features have an axial spondylitis. And you'll notice I'm interchanging the names, spondyloarthritis, ankylosing spondylitis, axial spondylitis. So try to get used to it, because we do this all the time and we hope not to confuse, but they mean the same thing. So as long as it has itis at the end of it, you're on with the same thing. 80% of ankylosing spondylitis patients will have inflammatory back pain. And inflammatory back pain is relatively uncommon due to other causes. I said before, it's chronic, and the ages mainly less than 40 years. For inflammatory back pain, it's mainly men. It's got an insidious onset, and it's associated with morning stiffness, better with activity. So how do we find out what's inflammatory back pain and what's mechanical back pain? And that's the real goal when you see back pain. So there are a number of tools that have been created since the 1970s. You don't need to learn them off, but I'm going to show you what features in each of them and how you might design your own score. And it really doesn't matter if you're using a current one, but each one contains important facets of what is inflammatory back pain or how you might identify it when someone walks in the door. So with the Callan's criteria, the older one, they asked for age less than 40, back pain for 3 months of chronic back pain, an insidious onset associated with definite morning stiffness and improvement with exercise. And sensitivity and specificity goes up the more you've got of these. Another criteria just extended the age group, was similar otherwise. The Berlin criteria, back pain for more than 3 months with morning stiffness of greater than 30 minutes duration, improvement with exercise but not so with rest. Alternating buttock pain is a very good sign, and awakening in the second half of the night due to back pain. Sensitivity is about 70% and specificity about 81%. The more of these you have, the more sensitive and specific. If you just have one, think about it. And the latest inflammatory back pain scoring criteria is chronic back pain again, and at least 4 of these: improvement with exercise, pain at night, insidious onset, age less than 40 years, and no improvement with rest. And you can see they're quite repetitive. So there's a lot of science behind them going into sensitivity and specificity, but a lot of them are saying the same things. So what are the spondyloarthropathies? Well, there are 7 conditions that are all interlinked. So if you have one, you may have a higher frequency of having the other. Those 7 conditions, so ankylosing spondylitis, you've got your inflammatory bowel disease, Crohn's disease, and ulcerative colitis, reactive arthritis, acute anterior uveitis, psoriatic arthritis, we label as an undifferentiated spondyloarthropathy, and a juvenile spondyloarthropathy. We'll see something very similar in a minute. So the link is the HLA-B27 association. So to put it differently and say the same thing, the associations with sacroiliitis, iritis, spondylitis, carditis, gut inflammation, oligoarthritis, conjunctivitis, and genital inflammation, so those reactive arthritis. So this association was discovered, was thought about for a while, but it was discovered by two Yorkshire researchers, two doctors, Moll and Wright, in 1973. And I love this Venn diagram because I think it says so much about the associations with HLA-B27 conditions. Just never forget about the valvular heart disease or other cardiac problems. These are things that we try to review when we see patients in clinic, not just focus on back pain. So the associations with HLA-B27, well, it's 90% of patients with ankylosing spondylitis will have it. We'll find 10% don't. In reactive arthritis, again, it's really quite high, 80 to 85%. Inflammatory bowel disease, only 50%. In psoriatic arthritis, as long as its axial involvement is 50%, that drops significantly with peripheral psoriatic arthritis. It's also seen in Whipple's disease. So the epidemiology of ankylosing spondylitis. So it's most prevalent in the Nordic regions of Europe, so Norway, Sweden, Finland, Central Europe, Asia, and South America. Not so much in North Africa, but it's South African continent. So it affects about 0.5 to 1% of the population. Said before, it's got a male dominance. Unfortunately, it's usually a late diagnosis. So we used to say it was a 7-year diagnostic delay. It has improved quite a lot. This wouldn't have mattered when there wasn't any specific treatment, but now in the era of biologics, biosimilars, treatment can make a huge difference to patients. So it's not a diagnosis to be missed. Okay, so I really like this story. I find it heartwarming. So Leonard Trask, he gave one of the first descriptions, really comprehensive descriptions of untreated ankylosing spondylitis. So born in 1805, he had an accident in his early 20s when he was riding his horse. So a pig ran under the horse. He fell off and he had extreme back pain afterwards. He recovered, but seemingly other accidents came to play and he had more back pain. He was quite disabled, and he wrote he wrote pamphlet books which he sold for nominal cost to try and earn a living, mainly in the third person, called The Wonderful Invalid. And you can look these things up. It's such a lovely story. But I mean, he really endured torture. His doctors at the time really had no idea what it was. They were treating him with bloodletting, emetics, ice baths, anything, just brutality. He went to work in a circus for a while, but he did manage to father 7 children, even after his diagnosis. And he had severe uveitis by the sounds of his memoirs. So moving on from that. I don't know how that happened. Okay, so the natural history of ankylosing spondylitis is a highly variable presentation. In the early stages, it's characterized by spontaneous remissions and exacerbations, as Leonard Trask had described. But there is a spectrum of severity. It can be mild and limited to the sacroiliac joints, or it can be more generalized, affecting multiple areas in the spine, and can be severely debilitating in some patients. There's a pre-spondylitic phase that can be unrecognized, and this is the 5 to 10 year period where real damage can happen, real irreversible damage can happen, and that delay can be up to 9 years. So these patients, before they're diagnosed, they can often be labeled various things, can see multiple physicians, specialists, chiropractors, seek out a lot of alternative treatments, undergo lots of investigations, invasive procedures, and there are social consequences. So there's decreased work productivity, work disability, early retirement, and overall decreased survival. And in Europe, there's an average of 13 sick days per year for ankylosing spondylitis. So ankylosing spondylitis in numbers. So, okay, this is a little bit of overestimate, but 1 to 2% HLA-B27 positive individuals in Europe and North America. There are 6.7% of HLA-B27 positive individuals in Norway. So as I said from the map, higher in the Nordic European countries. 10 to 30% HLA-B27 positive and first degree relatives get it. 80% of symptoms before the age of 30. So take seriously young back pain, and less than 5% are symptomatic after 45 years. And there are about 3,000 new cases in the UK per year. So we've said this before, up to a 9-10 year diagnostic delay, depending on which article you read. It's the longest delay, unfortunately, of all the rheumatological diseases. The main reasons for this is difficult, and we appreciate this, it is difficult to weed out inflammatory back pain from mechanical back pain. And the symptoms can be quite mild, and with this remitting and relenting course, it can be easily missed. And there is really no definitive test you can do. A blood test, it might be negative, they might fall into the 10% that doesn't have a HLA-B27 positive. You might have a normal MRI scan. We'll go to that in a little while. It has a low prevalence, the progression can be slow, and the traditional diagnostic criteria can have its own limitations. So what do we know about the pathogenesis? We don't understand all of it. We do know that there's an interaction between HLA-B27 and T cell responses, and there are increased concentrations of T cells, macrophages, and pro-inflammatory cytokines, including anti-TNF. And you can find increased anti-TNF in the sacroiliac joints if you look for it. So inflammatory markers are the hallmarks of the disease. So inflammation in the center, as with our inflammatory conditions, generates reactions with bone reactive sclerosis and resorption, osteitis, cycle of bone remodeling, newborn formation and ankylosis. We also have synovitis. We often see this in reports, spinal reports, MRI reports, facet joint synovitis, and enthesitis. So enthesitis is it's quite difficult to see without imaging, but there are classical places of inflammation where the tendon inserts into the bone, and this is an enthesitis complex. I would trust patients if they have tennis elbows, Achilles tendonitis, patellar tendon insertion, tenderness. I would trust them if it feels like it's inflammatory back pain, that is an enthesitis. Such a brilliant set of patients recently, and they're all describing this letter I, and I don't know if it's something that's on patient forums, but it really goes a long way to explain the symptoms that patients will present with. So they had shoulder, axial skeleton pain, and hip pains. So they feel stiff in those areas. So if anyone says letter I to you, that's what they're talking about. So there's various things you can do. Is a reason for a restrictive lung defect. So we know that people with ankylosing spondylitis, particularly affecting the costovertebral joints, the thoracic vertebrae, are limited in how they can expand their chests. And this can cause problems. So normally you should be able to expand your chest at least 5 centimeters. We measure sometimes in clinic. It's a good thing to do. The chest expansions, and if it seems to be decreasing, we keep an eye on that. The current classifications of spondyloarthritis, we split it into axial and peripheral. So the axial can be radiographic or non-radiographic sacroiliitis. So we normally rely on MRI studies to pick up sacroiliitis, but even if it doesn't, we can still classify it as a non-radiographic sacroiliitis if we're convinced that there are a number of other criteria met, and I'll show you some lists of criteria in a minute. The peripheral spondyloarthritis is usually associated with psoriasis, inflammatory bowel disease, a preceding infection, that is a reactive arthritis, or with any of those, or without any of those. So these associations that build up a case for ankylosing spondylitis, they can be weighted differently. So the most influential sign is sacroiliitis at grade 3. So both sacroiliac joints involve both sides of the sacroiliac joints. So if that's on x-rays, in my opinion, it's probably a little bit late, but you get a very high likelihood ratio. If it's on MRI study, you get a lower likelihood ratio, but still very significant. HLA-B27 is equally weighted. And then things like CRP, good response to NSAIDs, family history, the uveitis, dactylitis is important, associated peripheral arthritis, heel pain, and inflammatory back pain. So how would we go about looking at this? So the ankylosing spondylitis International Working Group criteria for the classification can be applied to patients with chronic back pain, that is for 3 or more months, under the age of 45 at onset. So if they have sacroiliitis on imaging, you're done. If they don't have that, but they have a positive HLA-B27 marker and 2 of these features, that's back pain, arthritis, well, inflammatory back pain, arthritis, heel enthesitis, uveitis, good response to NSAIDs, family history, raised CRP, and CRP is more specific than ESR, then you've got enough. So you just need two or more of those. For the peripheral spondyloarthritis, arthritis of enthesitis or dactylitis plus any of the associations, just one of those will do, or less specific ones are arthritis, enthesitis, dactylitis, ever in their life have inflammatory back pain or family history of a spondyloarthritis. So I don't know that you will be doing this in primary care, but just to let you know what we get up to, we like to do the Schober's distraction test. So we measure 5 centimeters below the dimples of Venus and 5 above, get the patient to bend forward. If there's if it expands by 5 centimeters or more, then it's normal. Less is a positive test, a positive Schober's test. So Schober was a German. He developed this test in 1937, I believe. We also test the tragus to wall distance. So the head should be in the neutral position. Anything more than 15 centimeters is abnormal. For greater accuracy, you can do both sides, take the mean, depends on how much time and willingness you've got. The alternative would be the occiput to wall distance, and that should be 0. You should be able to bring your head back. Synthesiopathy, so I've spoken about this before. So yeah, they'll be tender, they'll be sore over the area where the tendon inserts into the bone, and so that is the complex. You might not see much on the x-ray, but if you keep x-ray and you start seeing this fluffy bony outgrowths where there's new sort of osteitis. Sometimes it's picked up earlier on ultrasound, and there's a masses index, but that's too much for you, and MRI will pick it up. Dactylitis, now this is really important not to miss. So if somebody is coming into your office and they're talking about sore feet and you're thinking they have inflammatory back pain, they might have had uveitis, make sure you take their socks off, because you don't want to miss these sausage-shaped toes. They're really quite specific. Same with the hands. They might have pictures on their phone, which is really helpful too. So again, just it's a little bit repetitive, but the extra-articular manifestations. So 20 to 30% will have an anterior uveitis, 33% an aortitis and myocarditis, or a AV block. You have to look for it. I mean, sometimes it's interesting because the cardiology colleagues, they don't often do HLA-B27, and they see all these things. So they might have that in isolation without an inflammatory back pain. And I really think they should look for HLA-B27 a little bit more. It was common to have gastroenteritis. I mean, there's a few papers that say up to 33% will have a subclinical colitis. And even if you do endoscopies, it doesn't come out as positive. 10 to 25% will have a pustular psoriasis, usually palmoplantar. Apical fibrosis is an association not seen very much now, but do differentiate between TB. And we uncommonly have any amyloidosis now because the treatment is so effective and the inflammation is checked in time. Just to go through, iritis is extremely painful and photosensitive. It's not something the patient thinks they might have had. It's not to be confused with conjunctivitis or any other red eye. They need to see an ophthalmologist. They need dexamethasone eye drops. So causes of iritis, so 20 to 30% of the time it's ankylosing spondylitis. About half of that in Reiter syndrome. Similar in psoriatic arthritis. much less in inflammatory bowel disease, and there's some cases, including vasculitis, that I have seen. So watch out for a hypopyon with the fluid level, just have a close look at the eyes. Mentioned palmoplantar psoriasis. Again, you might need to take the socks off for that. Nails are tricky when ladies are wearing good nail polish these days. The shellac nail varnish is covering a lot of this. Make sure you look for it, and sometimes you need a pen torch to look at subtle pitting. So on to imaging. So plain x-rays are useful, and hip involvement is quite a bad prognostic feature. And this 41-year-old patient of mine, really eroded hips. I'm going to need bilateral hip replacements. So you can find avascular necrosis as well as a cause for needing total hip replacements in the young people associated with inflammation of the hips. So if they're complaining, yeah, I mean, there is evidence that you should do some x-rays. Sacroiliitis, as I said before, both sides of the sacroiliac joint, not one side, and we'll go on to that. You might pick it up on x-rays. If you do, you've probably missed the boat, and they've been suffering for years. This is a patient I saw last year who was seen 7 years before in rheumatology and lost to follow-up, and had x-rays done at that point. And you can see that there's quite a lot of progression of the joining up the syndesmophytes on the AP view of the lumbar spine. Quite a lot of symptoms, and so 7 years you wouldn't expect to see such clear-cut progression. Again, on the lateral, you can see, yes, he had squaring of the vertebrae. You could even say he had shiny corners, which we call Anderson lesions. But 7 years later, again, they've joined up. It's very clear cut, and that spine will be much more stiff and difficult to bend. Bamboo spine, of course, is the end result of joined up syndesmophytes. There's very little movement when you've progressed to that. And that's really the goals of treatment. We really shouldn't be seeing these type of x-rays anymore in young people. Is there any role for nuclear medicine scanning? Not really. So, and even NICE have published a guideline saying really it is to be avoided. There's a huge radiation dose. It's not particularly specific, and we avoid it. The Anderson lesions show up very nicely in MRI studies. These shiny corners, usually more than one vertebrae. Thoracic spine is a good hunting ground for those. I know a lot of people tend to think, oh yes, it's lower back pain, it's lumbar spine. You find quite a lot in thoracic spine too. I mentioned the sacroiliitis is both sides of the sacroiliac joint, so it's bone marrow edema, at least in 2 consecutive slices, and it's got a higher sensitivity and specificity if it's bilateral. Okay, so this is a bit like sacroiliitis, doesn't it? But you've got to watch out for particularly multiparous women. It's usually in the iliac side of the sacroiliac joint. And this actually is condensans ilia, which is quite separate. You can do a HLA-B27 and you're stuffed if they have a positive one. But yeah, just be careful with that as a sign on an X-ray. So what about the treatment? So it used to be physiotherapy and NSAIDs. We know that anti-TNF alpha is overexpressed in the sacroiliac joint, so this became a therapeutic target with very good success. And it's recommended by NICE for several years. It's extremely effective for resistant cases. Treatment is for cases that need quite a lot of NSAIDs or COX-2 inhibitors. There are marked clinical improvements. We've been using them in the NHS since the mid-90s. There are radiological improvements, and there are improvements in quality of life and sleep. What can we say about NSAIDs? What should we use? What should we not use? Well, they're all not really good in the long term, and I think you know that. So quite a few studies come out warning of the cardiovascular risks, and these are particularly so in people with multiple comorbidities. There is an absolute increase in healthy users, but this is very low. So conceivably, if somebody wanted to use intermittent NSAIDs and naproxen would be the safest, it would be a feasible thing to do, cautiously monitoring, making sure that they were not developing any other risk factors and keeping an eye on the cardiovascular risks. Ibuprofen is an alternative. Again, ibuprofen and naproxen would be the safest ones to use if you feel you have to. UK thin database study. We know COX-2 inhibitors are poor in the long term with regard to cerebrovascular events. They compared that with NSAIDs. There is a risk with NSAIDs, not quite that of COX-2 inhibitors. And unfortunately, with ankylosing spondylitis, atorocoxib is probably our #1 anti-inflammatory beyond biologic treatment for treating patients that don't want biologics, but there are risks. So we have to weigh up the benefits and risks of every treatment. So there's Dr. Kruth came up with this idea that one of the problems was that the NSAIDs were inhibiting the cardiovascular benefits of antiplatelets, and extracted some evidence that this was so. It wasn't completely proven, and we're still waiting on other studies, but there may be an aspect in people treated for cardiovascular disease with antiplatelets that NSAIDs are somehow antagonizing or competing for the effect. Just briefly, I mean, infliximab was one of the first anti-TNF agents that we started using. The benefits, the MRI changes were profound. There was definitely healing seen. We've got so many now, so it's not right to talk about just one. So we're using biosimilars much more now than the original ones, but these are some of the early studies to show you the big difference in benefit between a biologic and a placebo, and a sustained benefit. We've got to get in there early before too much damage is done. And this is not my patient, this is Mr. Hua from the Huang province in China. So at the age of 18, he was diagnosed with ankylosing spondylitis. And you will remember the map I showed you of the world where ankylosing spondylitis is prevalent in China. But although he was diagnosed and that was good, he didn't have enough funds for any treatment, any specific treatment. So unfortunately, he went on for two and a half more decades with an extreme disability. I mean, eating was difficult. His chin was pressed on his thighs for the biggest part of his life, until charitably he had 4 surgical procedures, a number of spinal surgeons in China put him together again, and he was very grateful. It was an altruistic thing to do. But I mean, I suppose it's an extreme example, but ankylosing spondylitis is not a benign condition. It needs to be treated, it needs to be addressed, and we can help, but you need to look out for it. So the take-home message is chronic back pain is common, too common for you. Inflammatory back pain is not common in mechanical conditions, and 14% of those will have ankylosing spondylitis. HLA-B27 is helpful, but it's not the ultimate test. Ankylosing spondylitis is not benign. Remember Leonard and Mr. Hua. It's treatable, and early treatment prevents disability and job loss and absenteeism and presenteeism in the workforce. So as Braun said, it's chronic back pain that's important rather than inflammatory back pain. I think they're both important and need to be looked at. And this is from Leonard Trask's memoirs. Thank you. I'll take any questions.
Thank you very much for that. Okay, so we don't have any questions in the chat just yet. We have an observation, I think. Spade AX tool combines all of the AX tools and it's very useful.
Spade X?
Spade AX. I don't know, Christy, if you're here, do you want to expand on your comment?
Hi, Dr. Doherty. Yes.
Hi, Kirsty. Do you want to tell us about Spadex? It's not the index we use.
It's a website that's got the kind of a combination of all the different ASAS and Berlin and the other criteria, and it also looks at the extra articular signs. So it's a bit like the DAS 28, but an equivalent. So it's on stands for. Hang on, let me try and get this right. Spondyloarthritis Diagnostic Evaluation Tool, and it gives you a score and recommends when you might want to refer on to rheumatology.
That's very useful. I haven't used that. The Ankylosing Spondylitis International Working Group have a lot of resources that they put together. They're brilliant. So basically they have multiple PowerPoint slides and you can download them. I think you have to download a few at a time, depending on what's the area of interest, but they have a huge library. So it's ASAS. And you can go on that for free. You can use them in your presentations. They don't mind. I've used some in this presentation, and we find that quite useful. But Spadex, yeah, okay. Maybe you can send on the web link, Kirsty, at some point, if you think it would be useful for the GPs.
Yeah. There's also a website, A-Stretch, which has got lots of YouTube videos with really helpful stretches and exercises.
And the NAS has, they used to have an app mainly centered on using the Swiss ball. It was a free app, although I think NAS has NASS has a component that they used to ask for membership joining fees. But it's worth checking that out as well for exercises to advise patients as patient resource.
Okay, a couple of things coming through. So if HLA-B27 is in 90%, the 10% HLA-B27 negative, does HLA-B27 correspond to disease severity?
Not really. So you can see that it's easy to have a diagnosis of ankylosing spondylitis without the HLA-B27 positivity. So if you've got the other components, the iritis, dactylitis, inflammatory back pain, you'll probably reach severity quick enough without having a positive blood test. So in my mind, having more associations and not having the blood test would be enough for me to feel this is severe and requiring treatment.
Can I ask you a question, please? Is this a disease of collagen disease? Because it involves the bones, it involves the ligaments, it involves everything.
Is it a disease of what? I didn't catch the first.
Sorry, is it a collagen disease? Because it's involving, I mean, I thought initially it was the ligamentum flava, which was the primary cause of, ankylosing spondylosis.
Is it? I still haven't caught.
I said, is this ankylosing spondylosis? Is this a collagen disease?
That's the word I can't understand.
Collagen.
What?
Collagen.
Oh, collagen.
Yeah.
Okay, thank you. No, it's not a collagen disease. So it's an inflammatory arthritis. So it has components of inflammatory arthritis, some overlap with some of the things that we might see in rheumatoid. And because it's in the spine mainly, it's got unique features of spinal disease. So not a collagen disease, doesn't fall into that category.
Okay, thank you.
Okay, so Christy's shared a few resources in the chat, so we'll make those available to everyone. And I'm just checking. I don't think there are any further questions or comments. Just as with previous presentations, lots of very positive feedback about the presentation. So thank you very much for that. Any final questions or comments or observations before we wrap up?
I observed we have got all the female rheumatologists now rather than the male.
We're not all female at the moment, no.
Because since I saw it used to be male, not very many females. Now I can see more female faces.
Well, Just today, maybe.
Oh, that's good. That's good.
Okay, no final comments, no final questions. Dr. Doherty, thank you very much for an excellent presentation. And I'd just like to thank everyone for joining us today, and also for dealing with the minor hiccup in the middle. I think we navigated that one quite successfully, so thank you very much. And I think we'll call it a day there and allow you all to enjoy the rest of your evening, and we look forward to seeing you soon at our next presentations. Thank you very much.